Sorry, say again.
You want it as a first presentation?
Whenever works for you, but if I could, yeah, get earlier in our session would be helpful for me in terms of preparing.
Um, is it okay for Dr. Gentle and Dr. Professor Vasakan? Is it okay for you?
No
Not a
problem.
problem. Yeah,
Yeah.
no problem for me.
I think, Professor, you can have your presentation first, then.
Okay, well, thank you. That would be helpful. I am here in the state of Washington, here close to Seattle, where I've been here skiing, snow skiing with my family, and so we're heading back to have to go to work here. So
Sure.
Did you go up to British Columbia?
no, we were in a place called Snoqualmie, which is south of
Uh-huh.
Seattle. It's near my son lives here, so
Oh, yeah.
we're doing that. So
They make a good Riesling, Snoqualmie.
yes, oh yes.
It's a little sweet.
But in India, facial plastic is picking up very well, actually. A lot of Dr. Gentle was asking about this. So it's 7 years back. There was, if you say it's facial plastic, no one understands. But lot of changes past few years.
Yeah,
So,
that's terrific.
and lot of youngsters been very much interested in this field, facial
Yeah.
plastic.
Good.
That's a good sign. We can see
Yes.
in another 5 years we can groom a lot of people in from India.
Yeah.
That's what we expect.
Are there a lot of plastic surgeons also in India?
Yes. See, as far as the facial plastic surgery itself, the plastics maxillofacial surgeons and are there, but it's like they have also doing a little job. It's been getting famous bit better now past 2 years. So not much work, but they have started. All the people have started.
Good.
Past 2 years. It's been better.
Even in UK, not many ENT surgeons are doing facial facelifts. It's still dominated by the plastic surgeons. So hopefully,
Right.
it's slowly, yeah. People have started doing now. So I think
Good.
next few years, hopefully there should be more interest among the ENT
Mhm.
surgeons.
So we regularly conduct courses. Every year we have at least minimum 2 courses we conduct. One for facial trauma and one for aesthetic one. We conducting since 2013. We are doing this regularly. So it's an ongoing process. It's going well, actually. So,
Mhm.
and a very good response from the people.
Great.
Got another 3 more minutes to start, Jayant. Is
Yeah,
it?
another 3 minutes to start. Just one second.
Is- I think really great that you are able to give up Sunday to come and teach. Professor Thomas, we really enjoyed, I really enjoyed the SCAR, presentation last week. It was really
Thank you
nice.
very much. Yes, it's an important part of my practice through the years, and important thing. I head up. I started a SCAR clinic at our university, and so an important area. So thank you very much. Yeah, I enjoyed talking about that.
How do I start? Where do I start with dermabrasion? Do I need to go to a course or something, or is it something simple that I can start?
Yeah, I think it's pretty simple. I think for a surgeon, I think it's pretty intuitive, and what layer you're in, and so on. And so it's fairly straightforward. And again, often, Dr. Gentiles, is an expert on all the various laser modalities, but for scar areas, I think, although I have all the lasers available too, that dermabrasion works very nicely as a secondary smoothing and blending procedure. So it's very helpful, but I think easy to learn and very intuitive in terms of layers and so on.
Part of
Thomas,
my
can I ask you, do you also use it for dark skin patients, this dermabrasion after scar revisions?
Yes, we have to talk to the patient about there could be some pigmentation differences and so on, but again, you're in the relatively superficial layer there, and so we do that. No question, lighter skin patients are better candidates here.
So I think we can.
And I think you can start now. It's yeah.
Very good evening, and on behalf of Isfaro, Indian Society for Facial Trauma, Aesthetic and Reconstructive Surgery of Otolaryngologists, we welcome you all to the second session of our aesthetic surgery webinar series. So far, we have successfully completed facial trauma, reconstructive, rhinoplasty, craniofacial, and aesthetic webinar series with tremendous response. Today, we are happy to have most distinguished and eminent persons in the field of facial aesthetic surgery as our speakers. Today's speakers are about the anatomy assessment and common techniques of mid-face and low-face by Professor Özkan Kekmak from Turkey. Then minimally invasive technique in facial and neck regeneration by Dr. Richard D. Gentle. Then neck lift and liposuction by Mr. Alvin D'Souza, and safety facelift by Regan Thomas. First, I would like to invite the first talk will be on safety facelift by Professor J. Regan Thomas from Chicago. Professor is currently a professor of facioplastic and reconstructive surgery, Department of Otolaryngology and Head and Neck Surgery, Northwestern University of Feinberg School of Medicine, Chicago, Illinois. Previously, various positions held are Manshot Professor and head of the Department of Otolaryngology and Head and Neck Surgery, College of Medicine, University of Illinois at Chicago. Then he was previously professor and chairman and Department of Otolaryngology and Head and Neck Surgery, School of Medicine, St. Louis University. Before that, it was a director on adult division of otolaryngologist, director, division of facial plastic surgery, College of Medicine, Washington University. He educated from University of Missouri School of Medicine. His otolaryngology residency, and then he did a fellowship in facial plastic surgery in 1979 in Northwest University Department of Otolaryngology. Leadership positions: President-elect of Illinois State Medical Society, President, American Academy of Otolaryngology and Head and Neck Surgery, President, American Board of Facioplastic and Reconstructive Surgery, President, American Academy of Facioplastic and Reconstructive Surgery, Chairman and National ENT Political Action Committee, Chairman, Council of Communication. He has written 7 textbooks and co-authored new edition of Cummings, and over 200 journal publications he has and textbooks chapters. He is editor in various facioplastic journals, and he has so many honors and awards, and he is a visiting professor and gives lectureships in 22 places. Over to Professor Regan Thomas for his talk. Thank you.
Thank you very much. That's an in-depth introduction. Thank you very much here. It probably reflects getting older. You have to be around a long time to do those things. So I appreciate being with you. Well, I will go ahead and get started here. If we can make things work here, we're going to share the screen and we're going to talk about good. And let's see if I can get this going here for us, and slideshow. So good. All right. So we're going to talk about what I call the safety facelift. There are, as you will hear this morning and are aware from other meetings and reading, there are multiple approaches to safety, to facelift. And I, through the years, developed what I call for myself and my trainees, the safety facelift. For a number of years, I was doing what is called deep plane facelift. We may hear about that, but thinking about the aspects of the safety factor and yet at the same time being able to get appropriate results, we've moved into and developed this technique, which I would encourage you to think about. Basically, what we're doing here is a SMAS approach, a two-vector, two-layer facelift, and one that I think works well. So nothing else to disclose, and please don't take any photographs of the patients here. The things I'm going to discuss here a couple of years ago, put out this facelift textbook that goes into detail, and our other textbook here, the advanced therapy, also covers the so-called safety facelift in that fashion here. So with our patients and all of us, you know, you have this self-image of looking fairly youthful, and finally one day you look in the mirror and you look like this here. So the classic aging kinds of look here, and become a potential candidate for facelift. But all the predictable changes happen to all of us, and all the things that Dr. Gentile and I are seeing in the mirror every morning here that begin to happen to us as well here. And very predictable in terms of aging changes. And so those are obviously the sorts of things that we'd like to change and get back into a somewhat more youthful appearance. And so that's our goal. We've discussed in the past and actually published, you know, what's happening with the anatomy and the pathophysiology of facial aging. And we're trying to return some of those. They're very predictable. And so we see a laxity and looseness of the muscle layers, but also the cheek fat and so on, the kinds of things that in a physical way, we can talk about what's causing that. And these are the things we want to approach with our surgery. It's important to make the patients understand they tend to think that this is simply tightening the skin. And to get an appropriate result and a long-standing result, you know, it's those deeper layers and other restructuring of the face that we're doing more than simply just tightening the skin with that. And so that brings us to what, again, I'm calling the safety facelift. And really that title comes from my trainees to make them think about what are the aspects that we want to avoid complications, and yet at the same time have an appropriate result. So that's this so-called safety facelift, which again is this two-layer, two-vector SMAS type lift. There are a variety of ways of approaching, you know, deep plane and so on. There have been several studies, including one we did back in the past, that shows really, if done well, there's not a real difference in what you're doing. And so thus I feel it's important to do what is the safest if we're getting appropriate results with that. So after doing an analysis of the alternative techniques, we ended up with this technique I'm going to show you, which again allows us to get to that acceptable level of improvement with a minimum of risk to complications, and that's our goal. So basic steps as we go through that are these: incision planning. There are a variety of ways of placing our incisions. What looks the best, what avoids complications. Submental correction needs to be done in most of our patients. excuse me, how we do the flap and deal with this mass here. So incision planning here, variety of ways, but this is the typical incision for me. Some individuals you'll see are putting the incision in front of the hairline, and the feeling there is you're not altering the hairline. The problem is that sometimes that's a visible scar. We, in most of our patients, we're doing post-tragal rather than pre-tragal, with the exception of our male patients, we do it in the pre-tragus, and then back in, and then rather than along the hairline again, I'm usually hiding my incision within the hairline so scars don't show with that. Some alterations, sometimes if a patient's already had an incision somewhere, we may use that, or as I say in the male patient, we are not doing post-tragal because we don't want to bring the beard back up onto the tragus of the ear. So there are a few occasional changes that we are doing that. So step one for us usually is the approach to the submental correction, changing submental fat and platysmal bands that are typical there. And so we are using those two steps of liposuction as the initial step in the submental area, and then platysmal plication, and I'll show you. A variety of types of instrumentation for liposuction. I like to use these flatter ones that I think will go underneath the skin easily. So I've marked the patient with the patient in the preoperative area in the upright animated position, so that when they're lying down, all of that tends to drift away. So I've marked these things ahead of time. Then I start with this small incision, the submental area, and do liposuction here. Once I've done the liposuction, and then I extend the incision and go down and undermine this whole submental area so that I have a view of the platysma bands, which we want to correct. And so for the platysmal banding, we are using that extended submental incision and go down and find, I'm going to plicate, but a key area here is I make this horizontal incision at the cervical angle. I mark that preoperatively where I want it to be, and as I'll show you here, that really helps define the cervical angle. So not just plication and bringing these together, but to also do our division here. So liposuction, and then defining the platysma. I go down and at our cervical angle, divide the platysma in this fashion, about 1.5 to 2 centimeters here, and then plicate, bring together the rest of this to help support, bring this back up as you had in the youthful neck with that. So we identify those margins, those edges, clean that up, get rid of the fat. Sometimes there is some subplatysmal fat that we're using. We break up what I call the verticality, the vertical lines here, by making our horizontal incision. Here's in a cadaver model, and so we've extended this. This is not our usual incision, of course, but extended so we can see the anatomy. So here's our platysma. After we've gone down to that layer, we undermine the platysma so we have the muscular flap to bring across, and we're going to eventually plicate that in the midline. At the cervical angle, as I keep saying here, we're going to divide that about 1.5 centimeters to 2 centimeters on either side. And once we tighten up above that, and then with that definition, it really helps define the cervical angle here, as you'll see. So I'm going to speed this up here quickly. So here's our liposuction. Now we're going to undermine. We've marked where our platysmal bands are. Liposuction. And we'll see if we can bring that up. Then we extend our incision, going down and finding our platysma now. We have that. Looking in there, I'm sorry you can't see, but we divide at that cervical angle, and then we plicate that. So that's basically working through that area. This is the same incision that occasionally we are also doing chin implants, and we'll talk about that later, but bringing that chin out really helps define the cervical area here with that. So once we finish the submental area, then we move on to the more traditional facelift area, the flap elevation of our lateral face in that. What I'm going to do here is do what I call the intermediate or the median flap, here's which I think is part of the safety area here. So step number one, we've done our incision as I showed you earlier here. And so I usually start in the temporal area. I undermine and make sure we're down by the temporal fascia so that we are avoiding the hair follicles. We don't want to lose any hair. And I only undermine this just beyond the hairline. And my experience has been where I used to go all the way out to the orbital rim, in fact, but you put that nerve at risk, your frontal nerves here, and I'm getting the same results and good results by simply elevating out to about the hair level. And then as we elevate our flap, we're getting the same result. So here I'm outlining in this area here, here's our incision and post-tragal. We are only going to undermine in this area out to the hairline, so we're avoiding those frontal branches of the facial nerve in that area, and we see those sometimes, and I'm getting good results with that. As we drop down at the zygomatic arch here, then I'm doing what I call the intermediate or median flap, not a long flap going out to this area that some may see, not a short flap, but this intermediate flap. And in the huge majority of patients, this gives us the ability to elevate the platysma, to bring it up into position and properly without getting out here where our nerves are at greater risk here, being more superficial nerve endings here and damaging the facial nerve areas here. So this is our typical outline of what we're doing in terms of elevation and incision. So with that, following liposuction and so on of the submental area. Once we've elevated our flap, and we are exposing the SMAS layer. Now, again, this is a 2-layer SMAS approach. As I say, I used to do the deep plane face lift, where after initial incision, basically you're elevating the skin and SMAS as 1 layer. The problem with that is, in my mind, is that how I need to elevate the SMAS is going to be different than how I elevate the skin in terms of direction here to get the best result. And so going back to this, I think I'm getting better results in it. So I'll show you makes sense. So typically then, once I've elevated my median flap out to the intermediate area here, then I define, reach in and see how much laxity I have of the SMAS, make an incision here, leaving a little band of tissue in this area from the zygoma on down. And now we're going to elevate the SMAS, but I only elevate it as far as the redundant SMAS will do. To go beyond that doesn't give you any more lifting and simply, again, puts other structures at risk. So we elevate that in this plane here, and we're above the parotid fascia here, easy to elevate. Once we've elevated all the way, we pull up and get rid of the excess, and then we close that again. But we do it in an appropriate vector here. So 2 separate vectors. That part going in front of the ear, we are elevating superiorly. That part going behind the ear, we're elevating, anterior to posterior, as I'll show you. So this is the plane of our SMAS here, and the ability to do this in 2 layers rather than deep plane, where that's sort of 1 layer. So in front of the ear, we're elevating the SMAS superiorly, from inferior to superior. The lower area from the mandibular arch and so on, we're elevating more anterior to posterior and suturing that into place. And that's different than how we're going to then, once we've done that and sutured it, how we're going to redrape the skin. It's perpendicular to that. In the face, I don't want to lift up. I'm going more anterior to posterior. And the opposite is true in the postauricular area. I don't want to pull it back. I'm pulling it up and superior to give us more elevation of the submental and neck area with that. So 2 different planes, and our degrees and direction of elevation are perpendicular. And doing the SMAS in this area allows us to do that, I think, superior to some of the other techniques of more deep plane area where it's more of a single layer. And remembering, we are being careful not to go out into areas. We're doing our intermediate flap and so on here, where we're avoiding branches of the facial nerve. So once we've done that and make our elevation, I make what I call my key sutures in place. So I place 1 here, usually with the staple at the hairline here, and 1 posterior. That holds everything in place. And then I carefully excise. An important part of the safety facelift is we don't want lots of tension. The tension on the SMAS layer is very strong. That's what's giving us our elevation. Now we are more redraping the skin. And so what happens here is that we're able to do that without tension and thus a better scar, as I'll show you here. So here's our model patient here, our key sutures in this area. That defines how much excess skin we have. We're excising that excess skin, closing the staples in the hair-bearing area. I thin out the tragal portion so it's not too thick. And then again, edge to edge, without tension on the skin, close that. And our closure here is, again, the key portion is without tension. I'm usually closing my post-tragal area with absorbable sutures here, like 6-0 fast-absorbing gut suture, proline and a running intracuticular area, and absorbable sutures in the back. I typically am very careful about hemostasis throughout this with bipolar cautery. and usually do not use a drain, but if you need a drain, you leave it there and bring that drain out appropriately. And then pressure dressings. So I'm going to speed this up quickly here, but there's my outline. And we're talking about how we're going to do that in this live patient. And so we'll go quickly here in the sub area here is my tragal area and around with my incisions. I usually make a little dart in the back, keep me from making the bridge. Now we're going to elevate here very carefully in that subcutaneous plane, exposing our SMAS here. I'm being careful not to include hair follicles to make sure I'm in the deep plane superiorly and posteriorly. Now I'm marking here my zygomatic area and my line of incision. And then I'm going to reach down, I'm past the angle of the mandible so that I'm pulling posteriorly from the platysma, elevate my flap here. And I only elevate out to how much where I have identified the amount of laxity there. To go beyond that doesn't help us in terms of improvement here. And so here we are going in a superior plane to do our platysma, or rather our SMAS suturing that into place and further redraping the skin. And now the skin, it's going to be edge to edge. I'm not pulling on the skin here dramatically. We don't want to have any pulled unnatural areas here. And so then careful closure and so on here, just to save time doing that. So doing that approach, what are the major complications I think we're doing with the intermediate or median flap of a 2-layer SMAS and platysma layer and a skin layer here? These are the major complications we're trying to avoid with our technique. And I'll go through those with that. So the hematoma, we are avoiding hematoma by a moderate flap. There's less surface area for bleeding because we're not going way out. We're only going intermediate here in our patients, along with careful hemostasis with bipolar cautery along the time. And once we've elevated that, that space becomes even smaller. So we really have a very confined space for potential hematoma. So not a big long space there that could potentially bleed. Here's a famous movie star in the United States that was seen in the airport. Somebody did his flap, but it lets you know that you could be in the wrong place or get hematoma. It looks like he had walking through the airport there. This is my patient, not a hematoma, but with all this ecchymosis, and it reminds me that I forgot to have her stop her aspirin ahead of time. So luckily we only got ecchymosis, no hematoma, but you need to be careful with that. We would obviously like to avoid skin loss. Here's some patients that I've seen for scar revision that had, probably way too much tension on this area, perhaps even cautery to it, whoever her surgeon was, but very unsightly. And I think the tension area, if you look at the rest of her scar, this hypertrophic scar probably relates to too much tension. So we have less potential skin surface at risk with our moderate flap, and doing a tight SMAS with simply redraping the skin reduces the tension on our flap. And it also helps us, that other major complication, avoid unsightly scars. So here are patients with these bulky scars behind the ear. I'm not sure what's going on with that. Look at this patient. Two things I would think of. I think one, there's too much tension here on the skin. They should have elevated with just the SMAS area here. But also, if you had hidden that in the hair-bearing area rather than along the hair-bearing area, even if you got an unsightly scar, at least it would be better hidden here. So incision placement along with appropriate tension helps avoid those scars. Here's somebody, the scar is okay, but they simply put it in the wrong place, too far away from the ear. I revised the scar and advanced that back in to get her in that place, and simply excising the scar and re-advancing with that as we're showing here. Here's another patient, not quite as bad, but still that scar showing up. It wasn't hidden as well as it could be. I've simply re-excised the scar, advanced that with careful closure, post-tragal and up under the earlobe here to avoid having these kinds of things show up with that. Facial nerve injury, a big one that we're all worried about as a complication. Here's someone, a very well-known surgeon, but inadvertently got the frontal branch of the facial nerve here. And so she has this. I treat her, by the way, with this Botox to even these areas out. But they could have avoided that, allowed her to keep her forehead moving by not going out into this area. So I stopped just beyond our hairline here. I'm getting the same results as I'll show you without putting the facial nerves at branch. The other facial nerves branches we are avoiding by not going out beyond our intermediate or median flap or moderate flap avoids those nerves. So with that. Hair loss, we don't talk about that as much, but when it happens, perhaps being in the wrong plane and hurting the hair follicles, it can be a problem. Also, too much tension, at least along the scar line, can cause loss of hair. And then using bipolar cautery helps at least localize cautery rather than monopolar cautery in the hair areas here. So here's a patient here. This is actually up in her frontal area here, but after a facelift, she came, as this hair loss. And I think I saw her operative note, and the surgeon says hemostasis obtained with the Bovie monopolar cautery, and I think he probably damaged some areas with that, being careful. This is not really hair loss as much as the flap has been pulled up too far. And so I'm always saying to my residents and fellows, just because you can do it doesn't mean you should do it. Don't retract the skin way up in here. And that proper hairline incision that I've planned would also avoid this sort of funny, strange look that the surgeon has gotten. Same surgeon, different patient, doing the same thing again. So very unsightly, and you want to avoid that. So our pre-hair incision, by keeping that in that area down here, and then our our post-hairline incision that I showed you, don't pull it up so far. You don't want all that tension. And occasionally, finally, here we do see some asymmetry. Be sure that you do the same thing on both sides. Here's a patient pretty happy with her facelift, except this asymmetry here. I simply did a unilateral facelift revision on her to make up for what her previous surgeon did to get symmetry in this area. So an interesting complication. Well, given that approach of the two-layer perpendicular incision, perpendicular tension on our flaps with appropriate incisions, do we get good results? And so that's the key. You could do all those things. If it wasn't giving you a good result, wouldn't be worth it here. So here's a variety of patients I want to show you. So fairly typical patient, kind of thick skin in this area. We want to get her jawline and jaw area and submental area done here. And we're doing that with our safety facelift. Look at her, we now see her mandibular line. We've created improvement of her jowls, formed the cervical angle in this area here, and yet with a natural look, not something that is too hidden from her. Patient very thin skin, very difficult because everything shows, but platysmal bands, laxity in this area. Here she is from the frontal view. We're getting her hairline or jawline rather straighter, getting rid of her platysmal bands, and with that, even with that very thick skin, thin skin rather. Lots of lower neck area here in our tight approach to this. Not only improves this lower neck, but these big jowls, and we're getting her up into a natural skin line here with this approach here. So from this look to this look, all with the safety, avoiding facial nerves and a safer approach here. It's more challenging patient again with very heavy neck. We're getting this neck corrected with our cervical angle and bringing her back up into natural neck. An even bigger neck in this area here. So lots of liposuction, using our SMAS and the proper vectors of force, which is perpendicular to how we want to elevate our skin, and going for this very thick, bowl-like neck here to a cervical angle, which she didn't have before, corrected jowls. Here she is a year later, still holding up really pretty well with that. And again, typical patient here, correcting jowls, bringing her face up into appropriate demarcation here, correcting the vertical or the cervical angle, jowline improved, this area here, all with very safe sort of approach here. So very thick skin. I did not do her nose, by the way, whoever did that. And getting her up from this look to a more natural but more youthful look, from this sort of thing to this area, all with that approach. And just other patients here, low neck thick area. I tell the patients the lower down it is, the less it will be improved, but we can do a really good job of, again, defining that. A variety of types of patients, and even very thick skin here, liposuction, tightening of the platysma, and getting her up into improved area with our safety approach, going from this look to this. And just finalizing again with that. So the advantages of what I call the safety facelift, we are hiding our incisions in the hairline and so on, not along the front of the hairline. Our intermediate flap is avoiding the facial nerve. Two different vectors. Our SMAS is going different and actually perpendicular to our skin position. We're closing then without tension on the skin. and that we are minimizing the potential for hematoma because our flaps are smaller. And as we bring those up into tension, there's less potential space for hematoma. So you want to be truthful with your patients of what can happen. So, you know, this before and after here in this bird, maybe not quite accurate here for us, but our goal with the safety facelift is to have the most acceptable benefit with a minimum of risk. And so with our patients, we go from this look, a pretty lady here, to getting her up to a more youthful face and neck, chin line here, correcting her cervical angle, improving her jawline. We are changing the skin so that these lines are not pulled in some funny direction, but in a normal direction rather than having to pull it up, because our SMAS is what's elevating and so on deeply with that. We go from this look to this look in our patients, all with avoiding facial nerves, minimizing potential hematoma, and hiding our scars appropriately. And this is our result that we want to get from this, but doing it in a safety facelift approach, doing it a safe way, minimizing those complications there. So with that, see if I can get back out here. Let's see, I'm going to end this and stop in my share, and we're back. Okay. Any questions or comments? And I would just add here at this point that, of course, as we'll see here today, and you see at other meetings, there are a variety of ways of approaching this, and everyone is getting good results, or you wouldn't be doing it. But if you can get good results doing steps that minimize potential risk to facial nerve, minimizing the amount of hematoma formation and bleeding, and hiding our incisions in ways that they are not likely to show. They're not out in front, they're hidden in our hairline, hiding our incisions. I think if we can get good results doing that with less complication problems, we have happier patients and we remain happier as surgeons ourselves. So thank you very much.
Thanks a lot. Fantastic presentation. Prof, I just want one question. How do you manage bilateral, that is a discrepancy in the face lift if it is post-operatively?
And ask me that again. I didn't quite hear. I'm sorry.
Yeah, the difference between the both sides when you do a facelift, if there is a difference, how do you manage post-operatively?
Well, I think, quite frankly, that dramatic difference one side or the other doesn't happen very often. But if it does, certainly does occasionally happen, you point that out to the patient, and the goal is we are getting improvement on both sides. They have some sort of facial asymmetry. We may not be able to correct the asymmetry that they have in terms of their anatomy, but we can improve both sides and get them back to a more useful look. So I think the key there is discussing and pointing that out preoperatively with the patient. And then the same approach on both sides here to get improvement on both sides.
Particularly in the malar area, you see sometimes you see difference that when you malar area.
Yeah, and so we're elevating to get good correction. We're looking at our mandibular line, our potential, the improvement of the nasolabial line in here. So we're doing that on both sides, and you may in that patient have a little tighter SMAS layer. But again, all my tension is really on the SMAS. And because we're doing two different layers, the tension is on the SMAS and the skin is more redraping and not really pulling on that. Again, gives us a more natural look, avoids inappropriate scars because there's not tension on the scars. And my skin excision ends up being edge to edge without having to pull the skin up dramatically to that. So it's all elevated based on what we've done with the SMAS. And there is tension on the SMAS. We're pulling that really to get everything up. The skin, we're trying to be more appropriately gentle, if you will, with the skin in terms of our closure.
Any other questions, Bhaskar?
One question. Would you do any additional procedure like rhinoplasty or blepharoplasty, or somebody needs a forehead left? Would you combine that, or would you plan that separately?
Yeah, no, fairly frequently we were doing, I think the most frequent thing I'm doing together is blepharoplasty. So facelift, I'm very frequently doing upper and lower lid blepharoplasty. Those patients who are getting a brow lift, I do most of my brows endoscopically, the incisions here and here, but again, can do that at the same time. So absolutely, those are things that you can do together.
Thank you.
You mentioned rhinoplasty. It's a fairly rare event that I'm doing rhinoplasty at the same time as facelift, but you know, it would be possible to do. But certainly blepharoplasty, forehead lift, and so on, you know, we do together fairly frequently.
One thing that should be always considered is patient safety, and this is about facelift safety, but also every kind of disaster you hear about in the States is when surgeons have attempted to do too much surgery at one sitting, fatalities and risk to the patient that is otherwise, you know, not founded. But if you keep like a 5-hour limit on surgery, you know, those things aren't going to happen. But there was recently one in Florida, and it was an ENT facial guy, and he was doing all sorts of out of the region surgery too. But you know, the patient was in recovery room, and the nursing care was questionable. But you know, keeping surgeries to a limit of 5 hours is always kind of high on my list of patient safety management.
Plus, Dr. Gentile and I have to be able to go to the restroom eventually. So, you know, 5 hours is about the limit for us.
This is true. What the butt can endure, sitting on the chair for 5 hours too.
Yes, exactly.
Good evening, Mr. Alvin.
Hello there. Just both Dr. Thomas and Dr. Gentle, thanks a lot for being here.
Hey, good to see you.
And
Absolutely.
Joel, can I just add one to the last question that you asked about combining surgery? I have on occasions combined rhinoplasty and facelift. Of course, blephs and foreheads, I often do them, but I did it about 3 times. But the last patient I did about 2 years ago, I had such a post-operative, you know, time with the patient because she couldn't breathe through her nose. She was feeling tight here. After that, I said to myself, never, ever again, you know.
Yeah.
And I think experience teaches you, like you said, you know, 5 hours is probably the most. And I will never again do a rhinoplasty and facelift in one go. That's my personal take on that.
Thank you. Yeah. Thanks, Professor. We will move to the next talk. Jerry?
Hi, sir.
Introduce.
Thank you, Professor Regan Thomas. It was a wonderful talk. Next, I'd like to introduce Professor Oskan Shakmak. His topic is going to be facelift, anatomy, assessment, common techniques, mid-face and lower facelift. Professor Oskan Shakmak is a European and international board certified facial plastic surgeon. He has focused on surgical rejuvenation of aging face and rhinoplasty for more than 20 years. He is the Rejuvenation Focus Group of the EAFPS and the Credentialing Committee co-chair of the European Examination Board on Facial Plastic and Reconstructive Surgery. Professor Shakmak, over to you.
Thank you. Thank you very much for your nice presentation. And I would like to thank Dr. Alvin Souza and all the organization committee members for this excellent organization. And I'm very happy and honored to be a part of this organization. Now I will share my screen. I think you can see, right?
Yes.
Yes.
Thank you. I'm going to talk about facelift, mid-facelift, mostly about anatomy and some practical sides to make the surgeries safely. These are my references. First, of course, if we're going to talk about anatomy, we have to start with CMS. Especially for beginners, I would like to mention about some details of CMS. This is a continuous fibromuscular layer enveloping the face and neck, and it invests, connects superficial mimetic muscles, forms a single anatomic and functional unit. So it gives the human face its unique mobility. At the forehead, it's continuous with the frontalis muscle. At the neck, it's continuous with the platysma. At the cheek, it invests in mimetic muscles. At the zygomatic arch, it's very close to the bone. Facial nerve branches are deep to the both smes and the parotomesenteric fascia. It means this anatomic arrangement allows the surgeon to perform extensive subsmes dissection safely. So as far as we are protecting the parotomesenteric fascia, we will be safe in most of the areas. Malar fat is superficial to the smes. Smes was investing the mimic muscles. This is superficial to these muscles. You see, this is zygomatic muscles. This is superficial to these muscles and also superficial to the orbicularis muscle and deep to the skin. So this is a subcu fat, subcutaneous fat. Retaining ligaments anchor the dermis, subcu fat, and smes to the bony periosteum or deep fascia. There are two bony ligaments, zygomatic cutaneous ligament and mandibular ligaments attaches to the bone. The rest are attaching to the deep fascia. These are mesenterocutaneous, parotid cutaneous, and cervical retaining ligaments. Retaining ligaments support facial soft tissues against forces of gravity. So it's resisting to aging changes. They hold the tissues on their places. But attenuation of retaining ligaments with aging leads to downward displacement of facial fat compartments, and this is responsible for many of the stigmata that occurs with aging. And most prominent aging changes occur anterior and inferior to these important ligaments. This is zygomatic cutaneous ligament, this is mesenteric cutaneous ligaments, and as you can see here, anterior and inferior to these ligaments, the smes is quite mobile. But posterior to this area, the smes is fixed. So aging changes occurs at that mobile area. So our aim is mostly improving this sagging tissues at the mobile smes area. So with this aging happening at the mobile smes area, we can see jowling, loss of definition of the jawline, marionette lines, prominent nasolabial folds, and with the changing of position of the malar fat, we can see some hollowness. When these ligaments are attaching to tissues and resisting to the aging, at the operation, when we are pulling the tissues, they resist to our pull. So in the operation, they just resist what we want to do. So it's often necessary to release these ligaments to get efficient movement at the sagging tissues. Releasing the zygomatic cutaneous ligament is important for malar repositioning. If you don't release the zygomatic cutaneous ligament, you cannot improve the malar fat descendance of the cheek area. So if the patient have prominent nasolabial folds, you need to release this zygomatic cutaneous ligaments to improve this aging changes. If we don't improve release the mesenteric cutaneous ligaments, you cannot get perfect result with the lower face areas, jowling and the neck. But this is less effective. This is less important because with lower facelifts, there are no ligaments here. And without releasing any ligaments, you can get nice result at the lower face and neck. But for the upper parts of the face, you need to release these ligaments as well. Releasing the mandibular cutaneous ligament is important for correction of marionette lines here, but this is straightened anteriorly, so it's not that important in most of the cases, because when you pull this back, all these sagging tissues, this is more anterior and it doesn't cause a big problem in most of the cases. But if the patient has prominent marionette lines, it's the best to do releasing of these mandible ligaments to get efficient improvement here at that area. Cervical retaining ligaments are situated at that area, just at the entry border of the sternocleidomastoid muscles, and it's between the platysma and the sternocleidomastoid muscle. And releasing these ligaments is important for maximum improvement of the neck and mandibular contours. Without releasing these ligaments, you cannot get very impressive improvement, I believe, because when you release it and when you make a horizontal cut, I will mention a little later, you can get really nice improvement at the mandible borders, and you can get a very nice angle at the cervicomental area. The problem, when you like to release all these ligaments, it of course carries a risk for fascial nerve injury. So let's talk about fascial nerve a little bit, because of course we need to protect the fascial nerve during our dissections. Fascial nerve branches travel deep to the parietomesentéric fascia, as I told you, and pass a more superficial plane before reaching their respective target muscles. So when they are reaching to their target muscles, they get a more superficial plane and they pass the parietomesentéric fascia. The exception, cervical branch immediately penetrates the deep fascia after exiting parotid gland. So it becomes superficial just after leaving the parotid gland. Maintaining the integrity of parietomesentéric fascia during extended subsmess section protects the fascial nerve injury. But it's still difficult to distinguish ligaments attachments from nerve branches during dissections, because complete release of the ligaments carry the risk of nerve injury. There are some danger zones where the nerves become superficial and where it transverses between the retaining ligaments of the face. For example, here, it's this nerve, zygomatic nerve, is very close to zygomatic cutaneous ligament. And here it becomes very superficial, temporal nerve. So in different areas, and here mandibular nerve becomes very superficial. So in different areas, there are some extra risks for some nerves, and I'm going to talk about them one by one. So let's talk about the facelift techniques. In which technique we can safely manage the operation, and what we should be in which points we should be careful to get a safe and nice result. Let's start with subcu lift. Subcutaneous lift involves dissecting a skin on the flap, excising the redundant skin, and closing the incision. So there is no any soft tissue improvement, and we don't touch the soft tissue. So the result is not natural and long-lasting. The closure of skin under excess tension carries a high risk of significant scar at the incision line. So we can use this only in selected patients where skin laxity is the main issue. For example, a year after the surgery, maybe if the patient has some skin redundancy here, you can just do a little cut, and just some after dissection, you can just tighten the skin. But it's in very occasionally you can need that kind of operation. What's the most common technique? This is the SMES techniques. Most common technique. Most of the surgeons perform SMES techniques. There are basically two forms of SMES techniques: imbrication and plication. Plication technique is, there is no doubt, this is the most common technique in the world. Also in my country, almost 80–90% of doctors are doing this plication. So the surgeon elevates the skin, then sees the SMES underlying the skin, and then just put some sutures to fold the SMES and tighten the SMES and fixes to fixed SMES area, this mobile SMES. So there is no any SMES dissection, there is no any SMES cut, just the sutures in a vector perpendicular to the aging. And this is the most popular one, Patrick Tonard's max lift, only putting some sutures after dissecting the skin. And this is another common operation, SMES imbrication technique. There is a cut at the SMES, maybe there is some limited dissection, subsymmetric section, or there is no any subsymmetric section. Just you can remove some wedge of SMES and just suture it to the fixed area, to more posterior area. So there are some different techniques, but basically at the imbrication technique, there is an incision, limited SMES dissection or no any dissection, and sometimes in some techniques removing some SMES and suturing this anterior part of SMES to the fixed area. So the effect is quite similar to plication one, but there is incision at the SMES. This is the most common imbrication technique, lateral SMESectomy of Baker. You will be really removing wedge of SMES and then suturing to more posterior and superior direction. When we criticize SMES lifts, I can tell that the pitotic SMES of lower face and neck is successfully pulled and suspended in superior direction. There is no doubt about that. But since the retaining ligaments are not released, there will be no midfacial aging changes improvement in this kind of operations. This is an example, nice improvement at the lower face and neck. There is nice improvement at the jowling, mandible, neck contours. These techniques, of course, adjust excess skin, improves wrinkles, but does not improve midfacial aging changes and nasolabial folds. So after some years, you can see this untreated area becomes much more prominent. Still, there's nice improvement at the lower face and neck, but without touching this mid-face area, I believe the results are not as good as some extent techniques when you compare. So if we would like to get some mid-facial aging changes improvement, we have to release the retaining ligaments straightened around the zygomatic bone. And of course, these are technically more difficult problems, and it's not possible to correct with the traditional. Traditional means classical. Traditional means imbrication and application techniques. So if you are doing traditional facelift techniques without releasing these ligaments, you can get that kind of results, because untreated mid-face area just gives a result of unopposed nasolabial folds. To improve this mid-face aging changes, you can get extra volume to the face, and it just makes the face is stuffed and operated appearance, and which I really don't like. And unfortunately, in my country, most of the facelifts are done, and in my country, patients have relatively thicker skin, and their nasolabial folds are quite prominent. And with this kind of patients, especially if you are doing just the traditional facelift and you are not touching the mid-face area, then you can get you should do some injections, and it makes really gives bad result. So maybe you can just release these ligaments to get improvement at the mid-face area, but most of the surgeons are hesitant to transect retaining ligaments during facelift surgery because of risk of facial nerve injury. If you are not able to do deep plane facelift or extended facelift techniques, you can combine your traditional facelift with the endoscopic subperiosteal mid facelift through temporal incision. So when you are doing this, you will be releasing the zygomatic ligaments at the subperiosteal level, and you will be improving all these mid-facial aging changes at the time of operation, but that will need a second operation at the time of surgery, and it gives, of course, additional time and work. But if we just see happens if you combine this traditional facelift and the endoscopic subperiosteal mid facelift. You can get nice result at the nasolabial area and nice improvement at the malar fat region. You can reposition the malar fat, and I believe you can get much more natural result and harmonious result if you combine. But again, if you do that, it will take much longer, and it will give additional risk for the temporal nerve when you are dissecting over the zygomatic bone. And I'm going to talk about that. But that was that's what I was doing before doing deep plane facelift. I was almost always combining my traditional facelift with the subperiosteal mid facelift to get nice result, especially with the patients with thick skin and heavy skin patients. But now I perform extend facelift techniques to improve the mid face area, so I don't need this operation to combine nowadays. So let's talk about extend facelift techniques which involve release of zygomatic cutaneous and masseter cutaneous ligaments. These are the actual locations of the zygomatic cutaneous and masseter cutaneous ligaments, and this is the dissection of the extended facelift techniques. You will be dissecting below the malar fat and just superficial to the zygomatic muscles and over the orbicularis oculi muscle. So mass dissection advanced toward the mid face along, as I told you, this area. So with this kind of operations, you will be repositioning the malar fat and improving the nasolabial folds. So releasing of these ligaments will allow you to reposition the malar fat. What kind of operations we can do as extended facelift? James Tuzin's extended facelift. In this operation, as I mentioned a little before, dissection is same. You are maintaining your dissection at the level just superficial to zygomatic muscles, and this is SMES flap. There is another skin flap. This is a long skin flap and SMES flap. You have two different flaps, and they are dissected separately. So first you are elevating the skin, and then you are elevating the SMES, starting from just anterior to the ear, and then you are dissecting all this area. High SMES lift, the horizontal SMES incision is placed higher. When you compare with this extended SMES lift, the incision is below the zygomatic level. But at the high SMES lift, horizontal SMES incision is placed higher over the zygomatic bone. So you can think that there will be extra risk for temporal branch. I'm going to talk about that, but the rest is quite similar with the extended SMES lift. And deep plane facelift of Samhamra, SMES is entered more anteriorly. As you can remember, at the extended SMES lift, the incision is just anterior to the ear. But when you take a look to the when you take a look to the deep plane facelift, the incision is at the level from lateral canthus to the angle of mandible and just posterior to the mobile SMES area. So in this operation, skin dissection is stops here. Then you go deeper and you elevate everything, SMES, skin, together as a one unit, as a single unit at deep plane facelift. When you compare with this extended SMES lift, there were two different flaps. But when you come to deep plane facelift, after this SMES entry line area, you are going deeper and elevating everything as a single unit. But the section is same. You will be over the zygomatic muscles, and you will be over, superficial to orbicularis oculi muscle, and dissecting all this malar fat as a single unit. And Samhamra's composite plane facelift, the dissection is similar as deep plane, just very, very similar, but there is additional orbicularis oculi flap. And according to Hamra, it allows more harmonious result when you have this additional muscle at your flap, at your composite flap. So when we compare basically the deep composite plane facelifts with the extended and high smash facelifts, we can see there is undermining of skin is different. There is a long skin flap at the composite and deep plane facelifts. You will be elevating a composite flap, and your skin flap is much shorter, and this gives excellent blood supply to the flap. So especially for smokers, there is less risk for the vascular problems and like necrosis, etc. So even for smokers, I can do safely my deep composite plane facelifts. Another advantage of deep and composite plane facelifts, since you are not elevating the skin at the fixed mass area, which is, I believe, not necessary because it's already fixed and you don't need to improve this area. There is not much aging changes at that area. We just need to reposition the tissues anterior to this entry line. So without this extra elevation, I believe this is more superior. And because you will be some problems with the temporal nerve in this technique, but you will be just anterior to the Pitengai line and elevating just very close to the mobile smash. And when you are closer, you can get much better improvement at the mid-face area, actually, from my point of view. So the completion of the traditional facelifts, improvement at the lower face and neck. When we are talking about extended facelifts, you will get extra improvement without any temporal approach to mid-face. You will get nice result at the mid-face area as well during your facelift operation. But if you will be doing composite facelift, then you will get extra muscle at your flap, and I believe you will get stronger flap, and you will get nicer result at especially upper nasolabial area, fold area, because when you have this flap to be elevated posteriorly and superiorly, you can get much nicer improvement at the upper mid-face area. This is, I believe, more superior than other techniques for that area. And there is a very interesting study recently published by Andrew Giacono, says that extend techniques while identifying and preserving the anatomy often leads to lower complication rates than blind working around vital structures. This is very interesting. This is what I exactly think because when I'm obeying the anatomy and dissecting the tissues, I can see everything below me and the parotid fascia, nerves, and if you really know the anatomy, I believe it's safer because everything on the table you can see directly. But at the plication techniques, you are suturing and without seeing the nerve, and deep stitches can cause some problems for the nerves, and you cannot be sure without waking up the patient. So this meta-analysis actually confirms my thoughts, and I really believe like that. And if you know the anatomy very well, this will be much safer than other traditional facelifts. So we have to go details of the fascial nerve to make these operations safely. And I would like to repeat, fascial nerve branches travel deep to the parotid mesenteric fascia, and SMES is superficial to the parotid mesenteric fascia. So you can safely elevate the SMES. And maintaining the integrity of parotid mesenteric fascia during ex and subSMES dissection protects the fascial nerve. But when we talk about some certain areas, let's start with zygomatic branch, it's not that easy because, for example, zygomatic branch is very close to the zygomatic cutaneous ligament, and this is very strong, very firm ligament. And when you are dissecting, it's not easy to distinguish if it's a zygomatic cutaneous ligament or zygomatic branch of the facial nerve. And this is a strong ligament and requires sharp dissection, and maybe most of the surgeons stops here and cannot go more anteriorly, and this is the main problem at extended facelift techniques. In extended facelift techniques, the way to release this zygomatic cutaneous ligament is in all techniques. I will talk about that. Starts with going just superficial to the zygomatic bone, and then finding the orbicularis oculi muscle, and then going inferiorly, just on the superficial to the zygomatic muscles. So first finding the orbicularis oculi muscle, then going inferiorly and following the zygomatic muscles and elevating all the malar fat. But it's not that easy. How we can do this dissection safely? My objective is I use prezygomatic space. So I'm not starting my dissection superficial to orbicularis oculi muscle. I go deep to the orbicularis oculi muscle, which is called prezygomatic space by Mendelssohn. And when I go just over the bone below the orbicularis oculi muscle, I will be just identifying the zygomatic cutaneous ligament and the zygomatic major muscle just anterior to this ligament. And it's very easy to cut this ligament superficially. When you come to this picture, this is zygomatic cutaneous ligament. This area is just deep to the orbicularis oculi muscle. So if we just first start our dissection at that area under the orbicularis oculi muscle, you will be seeing this ligament and very safely releasing this ligament. And this is my paper on this technique. I call this modified composite plane facelift with finger assist malar elevation. I will give some details of this study, and I believe you will be understanding why it's safer. This is orbicularis oculi muscle, right side of the cadaver. This is nose, eye, and orbicularis oculi muscle. This is zygomatic major muscle, and this is the actual location of major zygomatic cutaneous ligament. And this is very tight ligament, strong ligament, and we need to release this. When I put my finger in the prezygomatic space, this zygomatic cutaneous ligament will be a pivot point, just protecting my finger going down. And when I cut this superficially, there is no risk. And this is, you can see this is the zygomatic muscle just anterior to that. When you cut the superficial, you will be just entering to the correct plane very, very safely. So when I compare on the cadaver, deep plane facelift and modified composite plane facelift, I can show you that this is the regular extend facelift technique, orbicularis oculi muscle. You will be on the top of the orbicularis oculi muscle and following the edge of the orbicularis oculi muscle and going down and being superficial to the zygomatic muscles, which is not very, very visible here. But if we just go under the orbicularis oculi muscle, this is elevated already, which covers the head of the zygomatic muscle. And this is the actual location of the zygomatic ligament. You can follow very nicely the zygomatic muscle, and you can maintain your dissection just superficial to these zygomatic muscles. So if you are doing deep plane facelift, you'll be seeing the major zygomatic muscles like that. But if you are doing as a modified composite facelift, you will be seeing these zygomatic muscles that clearly. So this is the actual location of zygomatic cutaneous ligament, zygomatic major muscle, orbicularis oculi muscle, if you are doing very limited dissection below the orbicularis oculi muscle, that will be your pivot point for your finger or scissor resist to go down. That's definitely zygomatic tenos ligament. And if you cut this superficially, this ligament, you will be just entering to the correct plane very, very easily. And the discussion about the deep and modified composite facelift regarding this very small detail of the anatomy. This is another paper related with my paper at the Aesthetic Surgery Journal, published later. And this is the commentary to my paper by Brian Mendelsohn, and picture from his article. This is the real space, and the prezygomatic space is the real space. And if you are dissecting at the real space, you will be seeing the ligament in that area. This is zygomatic major ligament, zygomatic tenos ligament. It's like a tree, and the body of tree is very strong and very nicely visible there. If you are dissecting superficial to the orbicularis oculi muscle, you will be seeing the branching of the tree. And it's not easy to distinguish if it's a nerve or ligament. But if you are dissecting just deep to the orbicularis oculi muscle, and just very little dissection here, you don't need to go too far anteriorly, just to see the ligament. If you are going below the orbicularis oculi muscle, you will be seeing this pivot point and cutting superficial, and you will be just entering to the right plane. There is, of course, another space more superficially, but there are fibrotic bands, and this is not a real space. So you will have difficulty to dissect this area. But if you are at the real space, you will be just easily going just below the orbicularis oculi muscle over the bone, and you will be identifying the ligament very, very nicely. What I do with my finger, actually, you don't need to do just with finger. You can do some scissor dissection over the bone, very safe, and you will be identifying the ligament. But since it's first defined by Aston, I would like to mention about Aston's technique, because finger acimelar elevation was first defined by him. He does this finger elevation more superior and laterally, and just elevates up to the nasolabial folds, just superficial to the zygomatic muscles. But he doesn't cut or release the ligaments. And during his traditional facelift techniques, he makes this extra dissection, and he reports that the result at the midface area better. But in his technique, since the finger goes more superiorly, and since the orbicularis oculi muscle innervated from its undersurface, the frontal branch and zygomatic branch is going to the orbicularis muscle is under danger at original frame dissection. But in my modification, I just do very limited dissection here at that corner, just to over the bone, to good enough to see the zygomatic muscles, and I can just injure the zygomatic branch. And what's the scenario if I injure the zygomatic branch? The studies show that the functional innervation of the lower eyelid has multiple inputs. The removal of zygomatic nerves causes no abnormalities in normal blinking, eyelid closure, lower lid tone and position, or tear pump mechanism. So if I do a little dissection here and denervate the nerves innervating the orbicularis oculi muscle, it definitely will not cause any functional deformity to the orbicularis muscle. But surgical interruption of buccal branch here, medially, can have a profound effect on all these functions. And these studies show that if you cut this nerve, you will have definitely functional, very significant functional problems. So what I do in my modification, just releasing the ligaments, and to do this just to denervating the zygomatic branches, because I combine this area below the orbicularis muscle and I go inferiorly. So I denervate definitely some branches coming to the orbicularis muscle, but there is no any noteworthy muscle weakness in my hands. And also scientifically, this maneuver cannot cause any morbidity if you are doing in this limited area. And when I compare composite facelift and modified composite facelift combined with FAME, this is my modification, and this is the composite facelift. Hamra's composite plane facelift has a separate incision at the eye, subciliary blepharoplasty incision, and he does his suborbicular dissection from this blepharoplasty incision. So he does the same dissection, same elevation through blepharoplasty incision, and he does not combine this suborbicular dissection to his facelift dissection. What I do is I go deep to the orbicularis oculi muscle and I combine this to my facelift dissection, and I don't do blepharoplasty incision to complete my composite plane facelift. If the patient needs blepharoplasty, of course, I do this incision, but to make this modification, it's not necessary to cut the eye, and just combining these two planes are not a problem at the aspect of the functional problems of the orbicularis oculi muscle. But with combining the orbicularis oculi muscle with my facelift flap, I believe I can get much nicer improvement at the upper nasolabial fold area, because I have thicker, stronger flap, because I have orbicularis muscle as well. Because if you have a malar fat and skin, this is very thin here, but if you have also orbicularis oculi muscle, and if you tighten this area, mostly horizontal, a little bit oblique vector, you can get nice improvement at the nasolabial area. You can check it through the mirror. I was doing endoscope mid facelift. When I was doing that, it makes that kind of improvement. But if you are doing modified composite facelift, you will have much nicer improvement at the upper nasolabial area, which is the hardest area to correct during the facelift operations. Another modification from Hamra's composite facelift, he sutures to this area of his flap in a medial superior vector. This is from his original paper. What I do, I pull this orbicularis oculi flap, my composite flap, including orbicularis oculi muscle, in a posterior superior vector. So I believe it gives much nicer improvement at that area. The aim for his technique is just strengthening the lower eye support here, and he says that he's pulling at the vectors opposite the aging. But from my point of view, I pull this in that direction, and I believe I can get much nicer improvement at that area. So step by step, my technique. First, I do my skin incision and skin dissection. And this is the extent of my dissection. When I come to the ligament area, which is which can be marked before the operation from lateral canthus to angulus of mandible, and I stop my skin dissection at that line. And at the neck, I do my dissection all over the neck, and I combine both sides skin dissections. Then I go deep plane, and I elevate everything after that point as a composite flap. And first, I dissect subsmess flap till reaching to the ligaments. Here at the zygomatic tenos ligament area, I stop my dissection, And then I do my finger assisted malar elevation or scissor dissection to the prezygomatic space area. This is the orbicularis oculi muscle. If you feel the bone, if you just put your scissor and just open your scissor, and if you are below the orbicularis oculi muscle, which is very easy to understand because you will be just over the bone, everything will be just superficial to your dissection plane, and you will be at the real space. This is zygomatic cutaneous, this is the prezygomatic space of Mendelssohn. And you will be seeing this ligament here, and you will be seeing also the muscle, maybe, or just after cutting this, you will be seeing the muscle. So, because just anterior to the ligament, you should see the muscle there. And this is the finger dissection. You don't need to go that much anteriorly. And when you cut the ligament superficially, that's a pivot point when your finger there going, preventing your finger to go down. You will be cutting superficially and you will be seeing the zygomatic major muscle. And this is zygomatic major muscle. And you can release the additional ligaments around the muscle safely. Everything is under vision. And this is the video of my dissection. On the zygomatic area, I'm over the bone, and pivot point area, this is the zygomatic cutaneous ligament. I cut superficially, and with my finger, it goes very easily just over the top of the zygomatic major muscle. This is zygomatic major muscle. So you can maintain your dissection inferiorly very safely, and all this mid-face elevation happens just in few seconds or minutes, and without causing any morbidity to that area. I believe this is very important trick to make this operation safely. So after doing my modified composite facelift, this is the zygomatic major muscle, and this is the dissection, what I do, and this is skin dissection area. And I can nicely pull everything as a composite flap, and including the malar fat, and improve the midfacial aging changes. There is no any fat injection, just the modified composite facelift, and there is improvement at the upper nasolabial folds, cheek area, repositioning of the fat allows me to get nice result at the mid-face area as well. Another patient, improvement at the nasolabial area, and together with the neck and lower face, you can get nice result at mid-face area. Another patient, no any fat injection in these patients, just the repositioning of the malar fat bed allows you to get nice improvement at the mid-face area. Another patient. So you don't need to combine with the mid-face operation. Revision case, similar improvement at the nasolabial area and mid-face area. Let's talk about a little bit buccal branch. How we protect the buccal branch? It's impossible to release the inferior masseter cutaneous ligament with blunt dissection, but superior masseter cutaneous ligaments are resistant to blunt dissection. This means the inferior masseter cutaneous ligaments are very easily released with your fingers, and especially at the premasseteric area. This area is very easy to dissect, but superiorly, these ligaments, superior masseter cutaneous ligaments, are stronger, and you need to cut these ligaments with the scissor or the knife. And what I do, I first locate the masseter cutaneous ligaments by delicate vertical spreader action with a blunt tip scissors. Then after locating the ligaments, I cut them superficially, and with my finger I maintain my dissection anteriorly, and very easily and safely you can maintain your dissection. So it's actually easier to release these ligaments when you compare with the zygomatic cutaneous ligament. So masseter cutaneous ligaments can be most safely dissected like that. And marginal branch of the fascial nerve. This is very actually important because for the rest of the nerves, when we work on the top of these nerves, it's not a problem, but it's over the bone. And when you touch the nerve, this is very vulnerable. Even just touch this nerve, you can see some palsy at the marginal functions. And this will be very annoying. So I will give some details to prevent even the paresis after the deep plane facelift operations. So this nerve exits the parotid at the point of the gonion. And then it can follow a line just superficial to the inferior border of mandible, or it can be below the inferior border of mandible. So you cannot be sure if it will be superior or inferior. Both are possible. But anterior to the vessels, it's always superior to the mandible border. So till the fascial notch, it can be either below or superior to the border of the mandible, inferior border of mandible. But after the notch or vessels, it's always superior. Around that area, Osley said that 1 centimeter above and 2 centimeters below mandibular border, the nerve is very vulnerable, and extreme diligence in dissection deep to the platysma and CMS is needed to avoid marginal mandible branch injury. So this is the danger area. And when you look in details, the technique of Hamra at both deep and composite plane facelift, he stops his dissection at that area at the inferior border of mandible, and he just makes subacute dissection below this area. And his main aim, not extended inferiorly, is protecting the marginal nerve, because I really think about the same about the sensitivity of this nerve, because even if you touch this nerve around the bone, just above the bone, you can cause some palsy really. So we need to release the cervical retaining ligaments to get the nice neck contours. So how we will dissect the area, not to cause any marginal nerve palsy or even paresy. Is it possible? Yes, it's possible. At the modified composite facelift, all we know that the nerve is most superficial at the vessel area here, the vessels, it crosses the vessels. So I don't extend my dissection anterior to the masseter, anterior border of masseter muscle. And I don't go beyond to the notch here or vessels, because I know that it becomes superficial. And I know that there are not any ligaments here. So what we need to do is just releasing this, the cervical retaining ligaments between the sternocleidomastoid and the platysma. So what I do is I extend my dissection inferiorly, and to allow me to release these cervical retaining ligaments safely. So I don't extend my dissection too much anteriorly and without causing any morbidity, and I can get a nice result at the neck contours. So this is the most dangerous area, because the nerve becomes very superficial and much more vulnerable here. I used to dissect up to the mandible ligament too much anteriorly, but I saw some palsies after the operations, and in my cadaver dissections, I was sure that, and also the live surgeries, I was not giving any harm to the nerve, but it's very vulnerable, and you can see some temporary palsies if you really dissect this area, as Osley said. So what I do is I'm going inferiorly and releasing the ligaments, and then getting nice contours without causing this morbidity. So after changing my technique, I don't even see palsy of the marginal nerve. And there's mandibular ligament. How we can release this ligament safely? Should we continue our subsmess dissection and release this through this? As I mentioned, it's not safe. You can the nerve becomes very superficial, so it's not the safest way to reach through subsmess section. The safest way is releasing this ligament in a subcutaneous plane, and it's much easier to do through submental incision, and just doing a submental incision and dissecting this area and releasing the zygomaticotenous ligament just around the marionette lines is very safe and the very easy way to release this ligament. And you should know that just 1 centimeter above the zygomaticotenous ligament, there is marginal nerve. I told you it's over the inferior border of mandible, and it's very close to the mandible ligament. So you should be under the skin at the subcu plane to be really safe. And saying the same through the midline incision is the best way. Cervical branch, as I mentioned at the beginning of my lecture, I mentioned that cervical branch becomes superficial just after leaving the parotid gland. And because of this, it needs extra caution because it's very much superficial, and then it innervates the platysma. And we know that if we denervate this, not in all patients, but it can cause pseudo-marginal paralysis. So you can see some weakness at the lower lid in some patients, lower lid. So how we can protect this marginal nerve? First, my incision is little posterior to the line that comes from lateral canthus, the angulus of mandible. I used to do this incision just as a straight line, but I changed this to make everything safer for the cervical branch. I do little curve posteriorly, so I'm on the top of the parotid muscle. Otherwise, since it's very superficial, you can cut even during the incision. So I do little curve this, and first I dissect over the parotid, and then I continue my dissection with the vertical spreading actions of the Caesar. It means just like the parotid surgery, the nerves are always below you, and there is no risk to cut the nerve by this way. And again, my aim is just to release the zygomaticotenous cervical retaining ligaments. So I go just inferiorly, and I know that there are no ligaments here, and I know that the nerve innervates the platysma here, and it can also give some branches to the depressor lip muscles. It's not necessary to go far anteriorly at that level. Maybe more inferior you can go, but it's not necessary. So what I do is I just go inferior 5-6 centimeters inferiorly, and I release the ligaments, and then I do my horizontal myotomy. Here you can see this is my dissection, and my subsmess dissection is continued with the subplatysmal dissection here, and without causing any morbidity to the cervical nerve, you can release these ligaments. And this is dissection to going to the neck. It's called extend neck section, and releasing the ligaments very easily, very safely, without causing any morbidity, and knowing that nerve really becomes superficial innervates the muscle. And when you compare with the extensive SMES lift, high SMES lift, and my modified composite facelifts, actually all have similar dissection, just going inferiorly and doing their neck dissection inferior to the angulus of mandible and safely releasing all these cervical retaining ligaments. So it's not necessary to extend the dissection more anteriorly. And as you can see, all these three techniques do not extend dissection anterior to the vessels, and which is not necessary. But when you look to deep and composite plane facelift for Hamra, there is no dissection at the neck. But I believe if you do this section and do a horizontal cut and pull the platysma flap posteriorly, you can get much nicer improvement at the neck contours. And this is the horizontal myotomy and releasing the ligament, and you will have another flap of platysma, and when you pull it in a posterior superior vector, and it makes really this angle of mandible much more effectively visible and looking younger. And some results of this technique, and you can see you can get nice improvement. This is a revision case. Another case, nice neck improvement, even with the thick skin patients. And this is the last branch, temporal branch. Temporal branch becomes superficial at the area of the zygomatic bone, but it's also very close to the bone here. So it's not very easy to dissect that area. And we have to know the details of the anatomy when we are walking over the zygomatic bone. The nerve becomes superficial. This is our neck dissection area. This is the cranial part. This is zygomatic bone. So this is our subsymmetric section. And if you continue our subsymmetric section, we will definitely cut the nerve over the just after passing the zygomatic bone. And it's not that easy to dissect that area because there are very strong ligaments there, the attachments there over the zygomatic bone. If we just continue this dissection, or if we just continue our subgular dissection and just go in a same plane, or if we try to combine just the subgular dissection and the subsymmetric section of the face, you will be definitely cutting the nerve because it becomes superficial and goes just below the temporoparietal fascia. But here it's deep to the deep fascia, protomesenteric fascia. So we have to be careful. We have to protect the bridge here, and we cannot combine this to dissection planes. And what Hamra does, he protects the bridge at his subgular plane and subsmes plane. He calls it mesotemporalis, just like mesomandibularis at the neck. But the partial division of this bridge can be safely performed posterior to the temporal hairline because you will be posterior to the Pitangui line and the temporal nerve pathway. So you can just partially release till the entry border of the temporal hair, but you cannot combine it more anteriorly. And when we criticize the extent ICMS lifts regarding the anatomy of the temporal nerve, as I mentioned at the beginning of my talk, there is additional dissection at the fixed mass area, and the incision at the extensive mass lift is below the zygomatic bone. So this cut looks safer than high mass lift because at the high mass lift, the incision is just over the bone. So where the nerve becomes more superficial. But Barton says that it's safe to divide the SMS from the underlying parieto-temporal fascia over the zygomatic arc. So regarding these surgeons, it's safe to dissect that area. But from my point of view, I don't need to dissect that area because this is already fixed mass. And what I need to do is just doing my incision anterior to the Pitangui line. So I will be protecting the nerve without causing any morbidity for the temporal nerve. I just pull all these sagging tissues in a position that I really want. So I believe this is really one of the most advantageous part of the deep composite plane facelift when I compare with extended and high mass lifts. I would like to talk very shortly about the endoscopic mid facelift through temporal incision. If you want to do as an isolated procedure, I do that especially for younger patients, just having some mid-face aging changes, not very prominent changes at the lower face and neck. These patients are often between 35 to 50 years old. After that, these years, they have also some aging changes at the lower face and neck, and this operation cannot improve the lower face changes. But for mid-face area, in isolated patients, for example, some patients, you can something like that without changes at the neck. Actually, this is nice operation. But in this operation, this is my paper published in the JAMA more than 10 years ago about anatomy, how we pass the zygomatic bone when we are doing temporal, when we are doing mid-facelift through temporal incision. Our first dissection starts at the subgallial plane. When we come to the bone, we need to go deeper, just over the bone and deep to the periosteum. But how we can accomplish this? Because we know that the nerve is very close to the bone here, and Kuetala makes his dissection at this area, just attaching the deep and superficial layer of deep temporal fascia. He makes his dissection deeper. So he's deep to the intermediate fat pad, and he comes up to the zygomatic bone in a much deeper plane when you compare with the classical forehead lift. Because at the forehead lift, we do our dissection at the subgallial plane. And up to the 1 centimeters above the zygomatic bone, this is very safe plane, because nerve is just below the temporal parietal fascia. And when you are dissecting just below temporal parietal fascia, there is no risk. But we know that nerves from deep to superficial passes that line, and if you just continue your subgallial dissection, you will be cutting the nerve. So what I do is just a few centimeters above the zygomatic bone, I go deeper. I cut the superficial layer of deep temporal fascia, and I go inside the intermediate fat pad, and I go then inferiorly to find the zygomatic arc, and I cut the periosteum. Then I dissect all the tissues over the bone in the subperiosteal plane, including the midface, malar bone, etc. So this is the cadaver view of my dissection. This is subgallial dissection. Then I cut the superficial layer of deep temporal fascia. I go inside the intermediate fat pad. When I come to the zygomatic bone, I make incision to the bone. Then I dissect all this area in the subperiosteal plane up to the nasolabial area. And I also go inside the mesenteric tendons, inside the mesenteric tendons attachments. And these are the infraorbital nerves. And if you will be doing this through temporal incision, you will need Ramirez dissectors, because otherwise you cannot do dissection, and you need to do a cut through calvaldic incision, and you need to release all these areas if you don't have these special instruments. But if you have Ramirez instruments, you can do all these dissections through temporal incision. So this is on the real patient. I don't elevate the lateral canthal area because I don't want to elevate, I don't want to change the position of lateral canthus. But some doctors make this just for this purpose, and they call it almond eye or Bella eye appearance, which I really don't prefer. And my patients always say that, because even at the early period, I see this little elevation of lateral canthus, and they all say, it's too much elevated. Will it go down? I say, yes, in 10-15 days, it will go down and go to its normal position. If you don't elevate this lateral canthal area, you will not be changing the lateral canthus level, and the position will not change, definitely. But if you release these ligaments, and if you do this operation, it will be permanently going up, this lateral canthus area. But if you come to the operation, this is the zygomatic arc, and I do my subgallial dissection first. Few centimeters above, I do a cut to superficial layer of deep temporal fascia, and I go intermediate fat pad, and I come to the zygomatic arc over the bone, and I do my subperiosteal incision, Then I dissect all the zygomatic bone and the malar area with the special instruments. I release the ligaments at the level of bone, at the subperiosteal level, because this ligament is osteocutaneous ligament. At the deep plane facelift, we are releasing more superficial plane, but in that operation, we do this dissection and cut the ligament in much deeper plane. And then after this wide dissection, which is very important to get a nice result, you need this wide dissection, then putting a suture from here, and you suture all these tissues after releasing to deep temporal fascia. And this is the intraoperative view with Ramirez dissectors. You see, I'm coming up to the nasolabial folds. I'm inside the mesenteric tendons. And after this kind of wide dissections, you can get nice result at the midface area. The patient had undergone before facelift. She wanted only mid facelift. You can see how it improves mid face area, but it doesn't have much effect to lower face and neck. So for isolated problems, this is an ideal candidate. Just mid-facial aging changes and some fat injections, a couple of sessions, you can see nice improvement. So as a conclusion, understanding facial anatomy is essential to safely succeed extensive effective facelift techniques. It's important that the surgeon understands the relationship of the facial nerve to anchoring ligaments and the anatomy of the CMS and subcMS tissue spaces accurately to perform a safe and successful surgery. Thank you.
Thanks a lot. It was very detailed and very nicely explained anatomy and how to protect the facial nerve and different types of facelift. It's an excellent presentation. Can we take the questions right now, or can we have it a bit later?
Sure, we can take some questions. Yes.
Dr. Madan Gen Surgeon Erode, Dr. Madan Gen Surgeon Erode, or one other.
So, hello. Hello.
Hello, I'm hearing, yes.
I just checked that. So, for the extended one, you go beneath the orbicularis oculi muscle, the dissection. Can we go sublabially to release the zygomatic ligament? Is it possible?
Say again, please. You said I'm under the orbicularis muscle, and your question is if we do more superficial orbicularis muscle, right?
Superficial, I'm saying below. Sublabially, can we go and release that instead of going there and releasing there?
Absolutely. I actually did that for about 5 years. So I would do a complete subperiosteal release, then I would do a deep plane radiodectomy. But what we do now, what you can encounter there when you do that release of the zygomatic ligament, and then you pull everything, you can get a widening of the intermalar distance. So sometimes that has an odd effect. So I stopped doing that, indiscriminately. And now with a fat transfer cannula, I do a more targeted release where we're not releasing everything attached to the maxilla. But yeah, you get incredible improvements in the nasolabial folds. It just seemed to be an easier way, a more simple way to do that than coming from the forehead. When you think about it, coming from the forehead, it's a long walk to try and get to this area. So this is more direct and it is effective as well.
Yeah, absolutely.
My comment on that subperiosteal one is when you do subperiosteally, the stretching of all these tissues are limited. I mean, you are at the subperiosteal level, and the stretching everything, including the periosteum, is, I believe, harder. But if you are working on just soft tissues, as like deep or modified composite facelifts, it's you can see directly during the operation, nicely you can improve all these areas, because the problem is at the soft tissue area. But still, in younger patients, I do mid-facelift, because these patients often don't want any cut around the ear, and it's not necessary to cut there, and just doing the temporal incision and improving this nasal folds is good. But when I compare this, I think the deep plane facelift or modified composite is a little more superior than the mid facelift when I think about the planes and the effectiveness of the operation. But they both are possible, and you can do whatever you like. Yes.
Any other questions? I think. Can we move to the next presentation? Is it all right? Yes. We'll take the remaining. Jarin?
That is a wonderful presentation, Dr. Shakmak. And next, I would like to introduce Dr. Richard Gentle. He really needs an introduction. He's a distinguished facial plastic and reconstructive surgeon, a teacher and author who's known and respected internationally for his innovation, artistry, and technical skills. He received his BS in genetics from the Ohio State University in '78. He did a dual residency position in surgery and otolaryngology at the famous Baylor Medical College. Before it came trendy, he also did an MBA. Dr. Gentle has served in leadership roles in both the AAFPRS, where he was an executive board member and treasurer for the Accreditation Association for Ambulatory Healthcare. Prior to entering full-time private practice, he was at the Baylor College of Medicine, Texas, Case Western Reserve College of Medicine, Ohio, and Northeastern Ohio Medical University, Akron. Dr. Gentle resides in Canfield, Ohio, and maintains private clinics in Youngstown and Akron, Ohio. He has a long list of publications, and he's the editor of Neck Rejuvenation, a textbook for plastic surgeons published in 2011. Over to you, Dr. Gentle.
Thank you very much. I'm going to go ahead and share the screen here. And we should be live. Can everybody see that? So, good. What we're going to talk about is energy-driven neck lifting from the minimally invasive approaches to fully excisional, and how over the past couple of years we started to utilize high-frequency ultrasound dissection, and how we think that has improved the results and also helped to make certain things possible. And so this is just more bio. And in addition to my private practice, I'm on the staff at the Cleveland Clinic in Akron. And this is our center. And this was built about 4 years ago and features a state-of-the-art operating room, which is, of course, loaded with technology. And this is our kind of market area, although, we see patients from throughout the states, and but mostly Northeastern Ohio and Northern Ohio. And I always like to recognize my teacher, loving to teach myself. My general surgery training was under the direction of Michael DeBakey, and then Russ Kreidel and William K. Wright. And William K. Wright actually trained Russ Kreidel, but they taught me the fundamentals of facial plastic surgery. So in trying to seek new ways to do things or innovating, I think one thing to keep in mind is, as Leonardo da Vinci says, simplicity is the ultimate sophistication. And so when we look at what we can do by treating the interstitial space, that is the area under the skin and before the muscle layers, with energy, this started it all for me. I first saw this picture in 2006, and it was a marketing brochure for Smart Lipo 1064 fiber laser. And when I looked at that, I said, my goodness, this is as good or better than a facelift. And if a laser can do this, then everybody's going to quit having facelifts. So I decided to kind of learn more about this option. What I found is that in certain patients who have a lot of fat, this kind of contouring can come close to some facelift results, but it's not the right procedure for all patients. But that actually stimulated my interest. So if we look at using energy-based devices concurrently with surgery, and I think one thing about my approach is, I've always done facelifts and I've done these energy-based procedures, but I do them together. It's not one or the other. It's not like that you're just doing a laser type facelift and then not doing a real facelift, but we do them together. So when you use the energy-based devices, lipolysis occurs between 50 and 60 C, collagen structural change between 60 and 70 C, irreversible nerve damage. This becomes very important because when we first started doing laser-assisted facelifts, everybody was concerned that there'd be, facial nerve injury, but you really have to work hard to kill a nerve with heat. And usually we're not getting close to temperatures of 85 C, but you have to maintain that at 2 minutes. When you intentionally try to fry a nerve, it takes a lot of effort. So then you get thermal-mediated biochemical events, including heat shock protein release, and then of course the wound healing cascade, which leads to the development of collagen elastin hyaluronic acid, and then wound contraction 3 to 6 months afterwards. So I'm a cook. Also, I like to cook, and I like to use this temperature-controlled method, which is similar to temperature-controlled methods of surgery that I use. So in this, we're cooking this bistecca florentina in Ohio about a year ago. And so we set it to 133 degrees, and so that's 56 C. So after seeing that initial slide, you'll see that that creates lipolysis, but it's not the ideal temperature for reconstructing collagen. So basically, the question is, how do you like your neck? Do you like it rare? Do you like it medium rare? Do you like it medium? Do you like it medium well? But you see the energies that we're using between 67 and 70 degrees to contract collagen is really a well done neck. So with this skin retraction after this, basically a lot of these activities are occurring deep in the neck. So you get a thermal mediated subcutaneous fibrous and adipose remodeling. And I call this thermal fibroliposculpting, or sculpturing for short, TFLS. So basically what you can see in the area is a reconstruction not only of the dermal collagen, but of the remodeled fibroseptal network bands. And so that's where most skin tightening occurs. We've always thought of it as being dermal collagen thickening, but it's actually remodeling of the fibroseptal network. So we can do this with various devices, and I'm just going to touch upon them, for purpose. FaceTite is one that's really taken hold in the U.S. It was approved in Europe about 8 years prior to it being approved in the U.S. But it's really been well adopted. It's well adopted among plastic surgeons and some facial plastic surgeons, but plastic surgeons in the U.S. are really adopting this. Precision TX became the facelift version of Smart Lipo, and I was involved in developing this, and that was probably about 5 to 7 years ago that came out. You can also produce subdermal heating and tightening with just microneedle RF, because as the needles penetrate down to the dermis, and even you can go as much as 4 millimeters with these needles, you're applying heat to the areas in the deep dermis and of the remodeling. I'm going to show a patient where we use this mostly to perform lipolysis. Thermi RF, I was involved in launching that in monopolar RF, and it was something new and it was something we did. This has kind of been replaced by FaceTite at this point, which is bipolar RF. And Renuvion is the latest entrant to this. It's helium plasma, and it's a very hot device, but it's also limited. And so it's kind of interesting. We've been using this for about 5 years. And then finally, Vaser is something I worked with about 10 years ago. It's used a lot by liposuction surgeons, but this high frequency ultrasound is very helpful in doing facial dissections. And we've developed a whole set of protocols for this that we call Vaser Face. So why do this? So you can see this patient, Dr. Leonard Miller, plastic surgeon at Harvard. And so he did liposuction on both sides, but he only did heat on the left side. And in that area, with equal treatment, you see the advantage of heating the skin and heating the flaps. And the analogy is if facelift surgeon A and B do the same thing under the skin and do the same smash treatment and do the same releases. And I say that the patient that's heating the flaps is going to have the better result because you get this long-term skin contraction, which complements it. And that's something I've been saying 13 years, and it's starting to take hold. But when you're heating flaps, you have to be careful not to burn the skin. Of course, this would be the most dangerous part of that. But we all know where the skin burns relative to that. And so with temperature sensors and observation, you can avoid that. And as I said earlier, you're not going to cause nerve energy unless you superheat things and maintain that heat on the nerve. One of the other things that in the past couple of years have become more important to me in doing neck surgery are the retaining ligaments of the posterior platysma. And frequently you'll hear the cervical retaining ligaments mentioned, but infrequently you hear about the posterior cervical mental angle suspensory ligament. And so LeBay was the first one to kind of mention this. And we see it's more of a horizontal located ligament, and it's depicted there in the green. And in the black along the left, you see the more vertically oriented cervical retaining ligaments. So for optimal repositioning of the platysma, we advocate releasing these ligaments, and we advocate releasing these ligaments with a medial to lateral subplatysmal approach. So some questions come up then. Will posterior ultrasound-assisted platysmal dissection improve or make longer lasting neck results? Will we see less banding, less recurrence? Do these posterior ligaments attachments predispose to the recurrence of banding? Is ultrasound-assisted posterior platysmal release the preferred technique? And if any of you have tried to do extended dissections of the platysma from medial to lateral, you see it's like wet toilet paper and it falls apart, especially when you try to retract it. So kind of a soft touch approach will help. And this is what we're able to do with ultrasound dissection. And the most important question, of course, is this technique safe and free of unintended consequences? So you see here the dense attachments of the posterior platysmal ligaments. So I am under his platysma with a liposuction cannula. He's also under local anesthesia. And as you can see, as we try to get further, we meet the ligaments and we cannot do that. And here I've popped through there and I've completely elevated the platysma from the medial to lateral area. And then we just continue that and start to do that. So this shows how it's done. And basically we use the ultrasound dissector just to kind of come through these areas. And then we can extend a more substantial release. So it's a medial subplatysmal entrance and it's a lateral subplatysmal exit. So this is a lady I did a couple of years ago, and I became a real believer in the technique. On the left, her pre-op view, she had a neck lift by some non-plastic surgeon, like a gynecologist or someone like that, and that was her result. So I felt sorry for her. I didn't want to charge her a lot of money. So I said, let's do this isolated kind of neck lift procedure and see what we could get. So I elevated her platysma from medial to lateral totally and released all the ligaments. And I only did this through small incisions. So she had a prior incision in the posterior hairline. So through that, we were able to excise only that much skin, put our platysmoplasty sutures in and got that result. As you see, something I didn't pay attention to was the herniated buccal fat pad. And so what I did was with microneedle radiofrequency, I came back and repetitively treated that until I was able to shrink the buccal fat pad without any additional surgery. And then we see her pre-op and we see her final pro-op. And again, this was done under local anesthesia. And I was impressed with the jawline contouring that I was able to get without a facelift. So how do we do these procedures? Well, the earlier discussion of the face tight devices and all of those are just done through these little stab incisions. So really what you're intending to do through that is just to contour. It's like a augmented liposuction procedure. And as you know, after about 45, we don't like to do liposuction on the face because of concerns about sagging skin. So what these energy devices allow you to do is offer that to people who you otherwise would exclude because you would be concerned about their ability to tighten skin. We then do a short scar limited incision, and most of the time I'm doing like this Grecian urn. It's like a Lear incision. You can see it, and it tapers a little bit. When I've done shorter incisions that extend only partially behind the ear, you get a lot of bunching, and so we do this kind of fluted incision around the ear. So this is our short scar version. And then this is our full incisional approach that we do. And probably 80% of what I do are full incisions, and then, you know, a lesser amount of just facial contouring and a lesser amount. I think people in the past have thought, you know, basically I'm doing a lot of minimal incision sort of stuff, but really what I'm doing is implementing energy devices as a facelift tool. So these are the kind of results that you can get. And again, this is no incision, basically. We're just doing contouring. And this is with Precision TX. It was with the facial laser. This is from about 10 years ago. She's 26 years old, so she doesn't need a facelift or anything like that. So this is a patient who comes in, and this is one of the first patients I treated with Renuvion. And what we can see here is a near facelift result without any skin removed. And so this also involves, and on her, all I did was a medial platysmoplasty and not the lateral version. And so basically, the impressive part is when you look at a lot of facelift results, yeah, they're good, but are they getting those results without excising skin? And so that's something you have to think about as far as whether these technological improvements are worthy of widespread adoption. This is a patient I just did. He's a friend of mine. I did him about 3 weeks ago. This is non-excisional. And again, I took about 45 minutes to an hour to do this. He did get a medial platysmoplasty, and he got what's becoming popular in the States, a modified Elevate procedure introduced by Greg Mueller. He's a plastic surgeon in Beverly Hills. So we put some transcutaneous sutures. As you see, we actually do a skin puncture at the angle of the mandible. So we call this a Band-Aid neck lift. And basically he has only the stab incisions in this little skin puncture in which we run through the neck defining sutures. It's another example. And again, no skin was excised in this patient. And it's pretty remarkable that you can get that much skin contraction from using the energy devices. And so we did do the shorter incision. I did move his SMAS, but we did not excise any skin. So this is primarily a non-excisional result. So in this procedure on him, what we do, and what we'll see in some of the videos, is we do a full ultrasonic aided elevation in the subcutaneous plane to those margins. We then do a sub-SMAS dissection that's divided into an upper deep plane and a lower deep plane. So we're sub-SMAS with the energy device in the face, and then we're subplatismal with it. And again, that subplatismal dissection is started from the submental incision, and we do near complete release of the ligaments, and then we finish off the ligament release from the lateral incision. And we then move the SMAS as traditionally shown, but we do this all through an incision that has no posterior extension. So we see his frontal view here. And again, you know, these kind of results are not obtainable without a deep subplatismal dissection. I couldn't get results like that. And also what you see is nice toning of that central submental compartment. And you'll see a lot of post-ops, and there's always kind of some lagging in that area. The reason is retaining ligaments and the cervical mental angle ligaments and all those continue to try and pull those things back into position they were before they were operated. And with this, we're repositioning them in such a way, and we're creating a thermal seam, which is a new concept, but what causes kind of a three-dimensional retraction in that area, which is aesthetically important. So this is a full excisional facelift, and we're going to show some techniques. Earlier, Ozcan was mentioning the approach to the mandibular ligament, and we're going to mention our approach, but our approach and the hemostasis that can be obtained when using energy devices in the subcutaneous plane allow us to cut the depressor angli oris, which we did in this patient. This is pretty remarkable, and I've been doing these for a long time, but this is 24 hours after I totally dissected this patient in the superficial plane, in the subsmas plane, totally in the subplatysmal plane, and she didn't have a single bruise on her face. And I was kind of amazed at that. The other thing that's become important to me and that I've missed is the importance of subplatysmal fat in a lot of these patients. This is a study. Jim Zenz is the former chief of plastic surgery at the Cleveland Clinic. But in A, you see the distribution mostly of superficial fat in the neck. And in B, you see that. So you see in the midline, we don't have superficial fat. C shows the deep fat, the fat that I'm approaching subplatysmally with the ultrasound device. And then D shows some of the deeper fat. So that the important thing here is how patients age in C and how they develop fat when obesity is part of their problem. So I was watching this develop, and really part of it was I would have a couple of necks I'd have to go back into, and they had like a platysmal band that was like hanging a little bit lower. And it's because usually I did what everybody else did, really did a good central clean out, and then did not follow the fat under the muscle, okay? So one of the takeaway points, if you're doing these heavy necks, there's this little fatty extension that goes under that muscle. And if you don't address that, you're still gonna have some issues, and it may lead to the need to do a neck revision. I was watching one of the like Dateline or one of the news stories, and I saw this guy, and it just hit me. You can see the compartmentalization of his central fat extending to those lateral tongues, and you see it very well there. So again, surgically, everybody goes in, cleans out the midline fat. They don't clean out this fat. And so then, you get either continued fullness or the need to do a revision. So again, this is the distribution of subplatysmal fat. That fat is not superficial. And, that gets missed. And, that's why all this liposuction being done in the superficial plane may fail to correct these convexities. And you need to look a little bit further. Again, based on cadaver evidence. So recent technology improvements with high frequency ultrasound probes permits both lipoemulsification, thermal sculpting, and contouring superficially, as well as under the platysma and SMAS. And energy device use under the platysma and SMAS has not been previously described in literature or national meetings, although there's probably people that use electrocautery to develop their planes. But the problem with electrocautery is you get a lot of muscle stimulation, and it gets to be kind of a maybe unsettling kind of approach. So by performing HIFU first, the medial and lateral deep platysma from the mandibular border to the level of the hyoid is thermally sculpted during elevation. So we see that in the green depiction there. And then again, you get some etching of the mandibular border enhanced by the additional thermal sculpting in this area, both superficially and deep. So we're doing a superficial heat seam, and we're doing a deep heat seam now as well. So then you have these two distinct deep planes that develop. We can see that.
Excuse me, Professor Gentle, no, Dr. Gentle, is there audio is there or we are not able to hear the audio? Is it audio is there?
There's no audio?
No audio.
There is no audio?
No, we are not able to hear anything.
You're not getting any audio?
No, no audio.
Okay. Can you hear me?
Yeah, we can hear you.
Okay. I'll start to just kind of narrate this basically. So what we're doing now is the deep plane segment of the surgery. And what I like about this, someone asked earlier about symmetrical elevation. So with this, we can actually draw out the degree of elevation. So in this, I am doing 3 centimeters of elevation. And this is from the dissected deep plane flap. And then we're coming up to, this area there. And we also like to continue this over in a horizontal fashion all the way over to probably the mid-pupillary line. So with this, we're putting in this lacing suture. This is a suture that has barbs on it. And so basically we put this through here. We don't tighten the suture until all the suture placement has been played. But what you'll see here is the magic that occurs when you do that and you lift that face. So that's a 3 centimeter facelift. And I can say it's 3 centimeters because I measured that. So in this point, what we're going to be seeing is the lateral component. And one of the things I like about this technique is there's no cutting of the platysma. We don't have to do that to get the muscle to do what we want because we've fully released it. And by fully releasing it, we're able to, reposition it to where it should be. And when you think about aesthetic surgery, we shouldn't have to, make cuts and do all this stuff to reposition things to where they should be. But what you have to do is adequately release them. One of the nice things about the barbed sutures here that we're putting into the neck portion is you can go back over this and you can do what's a true corset because you keep on tightening a little bit. But you see the kind of definition that's possible along that jawline. And again, we haven't cut the platysma medially. We haven't cut the platysmal laterally. So we can see some results and the truly elegant kind of results you can get. This is 3 months after double deplane. And usually we take our post-op pictures at 3 to 4 months. This is a patient who's about 75. This is a revision lift. Patient who's about 70. We see at 4 months, her neck seems to have dropped, but then at 6 months, we see it back up, and that's the thermal contraction. This is, again, the perioral improvement with the gigalig improvement has really helped to, get the kind of improvement. So ultrasound assisted face and neck rejuvenation enhances results from surgery only. This results from ability to dissect multiple planes while simultaneously contouring fat and soft tissue and tightening skin. Very limited downtimes experienced by these patients, which combined with excellent results make this. This is published in August in Facial Plastic Surgery, and I'd like to thank you for your attention, and we can go to the discussion. These are my contact information here. So we're back to discussion, and so any questions about this evolution of technique?
So definitely, it was interesting, and it's very new for us from this part of the world. Not many people does it, obviously. How this technique evolved? Is it you said the face tight or something that you are involved in face tight and other two of the techniques?
What there are like energy driven facial rejuvenation can be like an isolated device only procedure. And so that is the most common application of it. And so with that, you would address, think of it as being augmented liposuction. And so in a double chin, it's perfect because you want to remove fat. And I'll amend that by saying it's not totally perfect, because it's not perfect if there is subpytismal fat. So if you only do a superficial procedure and you miss subpytismal fat, you will not correct the convexities that occur there. So a level 1 procedure is just to use heat and liposuction to contour the neck and then wait for the late effect of the remodeling that occurs at 3 to 6 months. Although when you do these patients and you take their bandage off, they're amazed by the results. They then go through some stages where things heal, they get a little tumefactive, they're hard, and then when that covers and it softens up, they go back to having really nice definition. So the second part is like throwing in a little bit of surgery. Either you do a medial platysmoplasty, you put a suture in, you do something to the neck, or you do something to the neck, and then you do a limited incision and do something to the face. You can get pretty good results with that because of the contouring you're doing with the microliposuction, and then also the skin tightening that you're achieving with the device. And then the third, the most common way I do that, I just use the ultrasound dissector now as my knife and scissors. So think of it, and Oscar was talking about fame, think of it as a hot finger. So I've got a hot finger that dissects because of the ultrasonic waves, and it cauterizes at the same time. So many of the visitors to our operating room comment that it looks like a cadaver dissection, and it does because the hemostasis is great. And that is the reason I started using these, was hemostasis. It wasn't to contract tissue. I wasn't aware of the other things that would be desirable endpoints, but I liked it for the hemostasis. It cut my operating time in half, and I rarely have to cauterize things if you do tumescent and then follow it with subcutaneous flap elevation. So, yeah.
Another question: is there any difference in skin texture? That is it stiff or something like that, post-operatively?
Is there any difference in texture?
Yes, that skin tissue was the using of the thermal.
Well, as you might expect from talking about the effects on the fibroseptal network, you're getting more skin tightening, and it's just kind of like we consider it an added kind of asset of providing heat to the facelift flaps. Because again, if you do the exact same surgery take out the same amount of skin, and then somebody who's heated the flaps, his result's always going to be a little bit better because you do get additional tightening and you get additional kind of skin correction as well. So yeah, we do see that. However, we'll do laser right on top of that facelift too. Tend to limit it in the central area. We don't really go over the flaps a whole lot, a little bit, but you can then do concurrent laser therapy after elevating the flaps with the energy device. And we really have gotten back to ultrasound, and it's perfect. I used it 10 years ago, but I kind of missed it. And so the new ring, the 5-ring dissector, is just incredible and allows us to operate in the deep plane as well, which is now starting to get adopted. These sort of innovations don't get adopted right away. However, it is a better way to do things. And I think from releasing the ligaments in the deep subplatysmal plane, I don't think you can do that conventionally too readily. You come in laterally, you can do it a little bit, but you can't get the degree of release that we can with the energy device. And that's what you hope technology will do, enable you to do things that you couldn't do before.
And another question is, how much it costs?
How much does the procedure cost?
No, the instrument.
Oh, the Vaser. The Vaser is not, compare like FaceTight is a very expensive device. In the US, $150,000, $200,000. The Vaser, probably around $80,000, $90,000 for the ultrasound dissector. And again, it's used frequently by liposuction surgeons, and that's how, I pretty much started to get familiar with it. But it's a very safe procedure. The lasers sometimes will heat things up too much. This is a softer application of the heat. And so, we find it's pretty much ideal for elevating that superficial plane.
Thank you.
Yes.
And we'll move on to the next presentation.
Great.
Thank you, Professor Gentle. Next, I'd like to invite Mr. Alvin D'Souza. He's a consultant in UK, Lewisham. He's the president-elect of the EFPS. He's the medical director of London Facial Surgery and London ENT Associates. He's the founder director of London Fact Courses. He's the editor of Facial Plastic Surgery of Otolaryngologist Journal and ENT Masterclass. He's been the author of chapters in books on rhinoplasty and facial reconstruction, examiner for various certified boards, American, as well as the European Board of Facial Plastic and Reconstructive Surgery. And he's an invited speaker for various world conferences in the field of facial plastic surgery. Mr. Alvin D'Souza.
Thank you very much. I will just screen share. Can you see my screen now?
Yeah, we are able to.
Yes, sir.
Okay. Are you able to see my slides?
No. It's gone again.
No.
Okay, just let me do it once again. How about now?
Yes, sir, it's visible now.
Yeah, the slides are on.
Yes.
Can you see the slide?
Yeah.
Yes, sir, perfect.
Okay. First of all, thank you very much. And I think it's been a great pleasure, actually, particularly joining Dr. Gentle, Dr. Thomas, and Özcan Çakmak. Very good friends, and from whom I always learn a lot every time I listen to this. So I think, as I was actually looking at the talks and listening to the talks, I've been kind of trying to delete some of my slides, add something else. So what I'm going to talk about in the next about 15, 20 minutes is a similar kind of ethos, but how I do things, particularly certain techniques that are basically dependent on my patients, to some extent patient-driven techniques. And like Dr. Gentle said, I think it's absolutely important that our patients want very little downtime. So if you look at this patient here, this is a gentleman who came to me. He's got a very heavy neck. And he said, I want surgery, but I don't want to be down for too long. And, these sort of patients are really difficult, unless, of course, you have, all the gadgets that Dr. Gentle has. I'm sure that he can do it probably in a much, better way. But I don't have all those gadgets, so I, take a slightly different route. So let me show you. And when you don't do these procedures properly, what you get is this kind of problems, where you are actually seeing this kind of cobra neck thing. And you saw this in one of the earlier presentation, sort of neck irregularities and things like that. So to me, management of face is one thing, but management of neck can be quite tricky sometimes. So generally, I feel, despite whatever I feel, is that the facelift, I think surgery is probably pretty much the standard for all these patients. And before I start with anything, I also want to find out from the patient what their main concerns are. And of course, I talk to them about the available options. And more and more, though I don't have the facility for all the, if you like, technology, I do work with one or two of the clinics who provide me with this technology. So I talk to patients about all these things. And obviously, we go through what is necessary for the patient. To get a good result, we need to actually assess the patient first, particularly in the neck area. And this classification here, kind of going from class 1 to class 6, if you look at the shapes of the neck, I won't go into all the details of it, but it's a level of the hyoid bone, amount of submental laxity you have. The result actually vary considerably. In other words, these sort of patients, class 1 and 2 patients, you can guarantee pretty good result. Class 3 and 4, sort of moderate. Class 5, 6, they are quite difficult to get good results, unless you do extensive other procedures, to improve the results to some degree. So it is important that, particularly if you don't have a lot of experience and you're starting off, it's important to understand which patients you can provide them with good results. So, based on that, you have to know what are favorable factors and what are unfavorable factors. And basically, suffice to say, if you look at all this, anybody who has a very nice, strong, bony structure generally does well after surgery. I like to see a full face in patients, because those patients who have very little volume generally don't get good results, in my opinion. And of course, the other things, there's operative factors like smoking and things like that. So one of the things about, I think, particularly if you're starting off with facelift surgery or neck surgery in particular, if you don't have a lot of experience doing this, and you're a new surgeon, and I know certainly in India it's not a procedure that's done routinely, I think you need to understand that you need to pick the right patient. Your complication rate needs to be minimal. So there are lots of publications as to what does help you in terms of minimizing complications. And there was a paper that I came across quite some time ago. It was called Evidence-Based Approach to Facelift. And I think it pretty much applies to neck as well, probably more so to neck surgery. And, who does get a hematoma in the neck, or which patients are more likely? Obviously systolic pressure patients with, males are probably, male patients are more likely to have hematomas. I must say, I've had very few of these, but if I take the number of men versus women, I do, certainly the rate tends to be higher in men, and all the other things. I do not tend to operate on smokers if I can help it, and that's because obviously I feel that the patients who smoke, probably are not going to do well in the long run. And I think you need to change the whole ethos of these patients' thinking if you're going to do these surgical procedures. Skin necrosis is very important, particularly when you lift those, extensive skin flap. And, we have spoken a lot about these techniques, whether you go for a deep plane, whether you go for a conventional, sort of reasonably smash kind of technique. And I think what has been good today in this webinar, I certainly find, is we've had very experienced surgeons talking about how to keep our patients safe. And I think I must agree with Dr. Thomas in terms of what he said. I think if you look at all the results, eventually for the patient, I'm not quite sure the results and the technique that you use matters so much, because they want to see reasonable results. Certainly my patients in London, they don't want to see like they've been all done up, but they want to look natural. They want to get back to results. So I think the technique matters to a certain degree, but it doesn't matter that much. So how do I do my procedure? Normally, I talk to the patient preoperatively. We have all the photographs and all the documentation of that, and then I inject the patient. That is a sort of cocktail I use to inject the patients. I don't do so much of liposuction now as like I used to do when I first started off. More and more, I tend to do direct lipectomy, and the reason for that is I felt that with liposuction, often, though on the table when I did the liposuction, everything looked great. When I saw these patients post-operatively with time, I felt I was not able to control the amount of fat that I could remove. So I now do a direct lipectomy. I must say, once I inject, I always take a sort of a break. And I think the reason for that is really that it takes a little while for your solution to work, for you to get good amount of vasoconstriction. And I think that is absolutely crucial. One thing that I always find, certainly in our residents, particularly ENT residents here, whether we are doing a thyroid surgery, whether we're doing any other form of neck surgery or any other surgery, we inject the local anesthetic and start operating straight away, and that is just causes more bleeding, because as you know, when you inject something, particularly the local anesthetic, the first effect is a bit of vasodilatation. You want to avoid that. And then, facial nerve, I think, the anatomy lecture today has been absolutely fantastic. I have nothing to add to that, frankly. And again, we spoke about the ligaments. The only ligament when I do in the neck, and I'm specifically focusing on the neck now, I want to release is to, a great degree, the mandibular ligament here. And I do release it very superficially, just literally under the skin. I don't go deep, because that's the safest area. And I do use a submental incision to release that. Incisions, they vary. For the neck, I always do a submental incision as well. But the length of this incision, obviously, for most of my neck, the incision starts somewhere around there and it goes to the back. And sometimes I do a back cut, sometimes I don't do a back cut. And we'll look at those in a little while. So submental incision is important to remove the fat and to do a submental lipectomy. And what I find in a younger patient, the fat tends to be well defined, and I think this is quite important. Now here, of course, I didn't do this the fat excision in this patient because of she came for a facelift, but actually she came to me for a rhinoplasty, and I had operated on her mother 2 years before, and she said to me, I have exactly my mother's neck, and can I actually get rid of this fat? So I did that. And the point I want to make here is, in some of the younger patients, the fat is well defined, and that is why I often prefer to do a direct submental lipectomy rather than use the liposucker. So and there are various options. As I said, older patients, the fat is more diffuse. Again, we can approach it using a submental incision. So there's a little video of what we do here. It's let me just try and reduce that volume, but I think you can see that kindly. So that's the infiltration going in. There is a lot of infiltration that goes in, and this actually does a lot of dissection for me. And then we have a submental incision. I tend to keep this sort of reasonably small, but I must say I'm not so fussed about how wide my incision is. So when I look at the submental fat, I often find it hard preoperatively to decide whether a patient has a pre or post-platysmal fat. And then that's why my submental incision helps, and I remove that. I do a platysmoplasty, and then we actually raise a smash flap. And you can see it's a very thin neck flap. And I want to undermine the neck all the way down. Okay, so I do a blind sort of undermining there, and I'm going to go forward to the next one because we'll be coming back to it in a short while. Now I've pretty much removed some amount of smash there. Now How much I remove, do I remove SMAS or I don't remove SMAS, to some extent depends on how much fat the patient had. You also saw earlier, I removed that little small amount of fat, and that is the jowl, and that is sometimes what I call the direct jowl excision, in particularly a very heavy neck patient. I do excise the jowl directly, and that is helpful. So in a very thin skin patient, I tend to use this kind of technique where again, what we're doing here is we're excising the, and you can see there's the platysma there. I've excised just a skin flap and I've raised the platysma, and you see the neck movement as I'm pulling on the platysma actually. And we are all the way down up to the submental area. So I've done the submental incision and done the submental platysmoplasty, and now I'm suspending that platysma using a vertical vector. Usually I put 1 or 2 vertical sutures here, and then I go slightly oblique sutures. So normally I tend to use at least 2 to 4 sutures, and then I close it with Michael repeat. So that's what I do in most necks. But then there are a very selected group of patients who don't want a periauricular incision at all. Now, in these patients, I tend to use this kind of incision. This was published quite some time ago. But what I've found is these sort of patients, and these are done often under local anesthetic. And again, what happens is that, we are mark the Z plasty there. It's a direct approach to the neck. And then I open up the neck, and you can see it is just a very straightforward way of doing it. Now, I definitely don't do this procedure in women. I don't think you can get away with it that easily. But in men, those who don't want the incision around the ears, and a lot of these men who come to me, they come for a specific reason. They all play in their golf courses, and they want to actually get back to playing very quickly. They don't want anyone to know they've had this done, so they can actually wear a heavy high neck polo shirt kind of thing, and then they can go back to what they're doing. So as you can see, there's a lot of fat is being removed, and once that the fat is removed, I'm still removing fat, and sometimes, once you remove the pre-platysmal fat, you open the platysmal layer. That is the fat that is behind the platysma, and then you can do a very nice, platysmoplasty. The important thing here is to let the patient know that they're going to have a midline scar, and that scar will show through for a little while, but over a period of time, over a period of about 6 months or so, that actually goes away completely. And then I close using deep and vertical repeat sutures. The closure is important. You really want to have a good subcutaneous or subcuticular closure, and then I always use absorbable sutures, so I don't have to take anything out from these patients' necks, and that is generally even for my facelift patients or any patients I do. So I always tend to use something like 6 or 5 or vertical repeat, and then I've closed that wound. Now, the other point that I want to stress to you, which you will see in a minute, is putting a dressing on. I put at least 4 layers of dressings. I put some steri-strips there, and on top of that, so that is important because, I leave it for a good 1 week. By then, most of it would have healed quite well. And then, when you remove the plaster, and that's, almost about a week later, you can see the incision line there, but it heals really well. Now, this patient is literally about 3 weeks post surgical intervention, and you can see, and he's quite happy with the results because he didn't want anything, other than that. So, this is for very specific people, not for everybody. That is a way of managing the neck. And you can see here, this is literally at the end of 3. You can see a little bit of tightening there, but that actually relaxes over a period of time. So it's one of the techniques that I use for necks. That's the lateral view. And if you do use a oral incision, often particularly with neck lift, the incision are actually slightly shorter. You can get this kind of banding, and it actually settles very well over a period of time. So we published a paper recently, and in that paper, I kind of highlighted how I deal with patients who actually have a heavy neck and who don't want an incision. And if you look at that, it's pretty much a patient-centered approach to neck rejuvenation, including scar preferences. So non-surgical is great, but a lot of people don't want non-surgical, or non-surgical doesn't often work, and that is, then we go for a surgical intervention. In female patients, of course, if they have fat and jowling and skin excess, you really need a perioral approach and a submental incision. If they have only fat in the submental area, then I just go for a submental lipectomy. Whereas in a male patient, it gets a little more difficult. Now, if they have significant jowling, and they actually have skin excess, I advise them to have a perioral incision and a submental incision. Now, if they refuse that perioral incision, then I mentioned these patients a midline vertical with a Z-plasty, which you saw, and I access, and the jowls are excised directly using that submental vertical incision. If they don't have any jowling and they have minimal skin excess, I do a submental lipectomy. And of course, if they have a lot of excess skin, I do advise them to have a perioral. And if they don't like it at all, then again, I do use a midline vertical Z-plasty. This is published in the sort of paper that has just been published online now, which will be printed very soon. But that is a very simple, basic way I look at the neck. Yes, depending on the patients, I sometimes do a slightly different approach. I change my approach depending on the patient, but that is basically what I wanted to put you across, because I think we've heard a lot about various techniques. But again, I think it's keeping safe is the most important thing. I haven't stressed on anatomy here at all, because I think we had an absolute fantastic lecture. So that is pretty much it. So I'm going to close at that. And once again, I want to thank Dr. Jayant for inviting me, and all our other speakers today. I think it's been an absolutely fantastic webinar. Thank you all very much for your time. I think I want to stop at that, Jayant. If you have any questions, happy to take that.
Excellent presentation, as usual. And it is the point very much that is it's more of patient-oriented approach will be better. It's nice actually.
I want to comment on one thing that is very important and sometimes gets missed, and Alwyn did it quite a bit, but direct excision of fat is a very useful kind of thing. And so when you've completed your liposuction, if you still see a lot of fat, you need to go in there and remove it. We typically use the Russian forceps. So we avulse this fat, and it will help give you that additional definition. And I can't say that I always did that back in the day. I would kind of rely on liposuction, but then you end up leaving a fair amount of fat. So be prepared to do what Alwyn did, and do the excision, and you have enough fat on the undersurface of your skin flap. So anything on top of the platysma, you can just remove. And that's one thing that is useful.
Yeah, that's absolutely. Richard, of you being there, can I just ask you one question? When you use dissection with the Vaser dissection, post-operatively, have you noticed any evidence of increased seromas or anything like that at all?
We had, in fact, the one patient that I showed that's like 1 month out, he did have a seroma, but I also used helium plasma.
Right.
The more energy, if it's just Vaser is kind of a lower energy, lower heat, so rarely with the Vaser. But if you throw in helium plasma, I have seen some seromas, but I have them so widely exposed, I'll just make a nick, put a little drain in, and they do fine and they don't get. But in thin-skinned women, seromas are a big fear on the neck because they could lead to like a cauliflower deformity that's really hard to correct. But we don't see any more than I saw previously. But yeah, you can get that with a lot of energy, but Phaser usually limits the amount of energy you see.
Thank you. Any other question, Dr. Jain, for me? Sorry, I digressed a little bit there.
Any other questions, Bhaskar?
No, excellent presentation. I really enjoyed. Such a very comprehensive. I think we learned about from the anatomy to all types of facelifts. Really enjoyed.
I think there was a question up in the chat questions about nerve repair medications.
Yeah, that's
So
what.
I think Lyrica is one nerve stabilization medicine. It's used for that. And, after these sort of procedures, numbness is a frequent complaint. But as they reinnervate, you can get dysesthesias. And that happens maybe in 3 to 5% of patients. But in that case, I've never had to prescribe it because I would just always tell them, well, let's see how you're doing in a couple of weeks. And they come back and it's less. But Lyrica is one thing I think that people that do some of these energy-based procedures, I think maybe the energy-based procedures might predispose to more regenerating nerve dysfunction, but we don't see it frequently.
Thank you. In fact, it is an excellent presentation and it's a very wide overview of from anatomy to basics to the advanced techniques, and we really enjoyed the session. I thank all the speakers for the excellent academic feast and good discussion. I thank the moderators, Bhaskar, Jerry, and our Isfaro team. I thank our academic partner, Medinews Pharma. On behalf of Isfaro, I will see you on next Monday, that is on 21st March, with the third session on aesthetic surgery webinar series. This will be on otoplasty and thank you. Thanks a lot.
Thank you, everybody. See ya.
Thank you.
Thank
See you.
you.
Bye-bye.
Seeing you.
Have a good Sunday.
Bye.
Absolutely. Bye-bye.
Bye-bye.
Bye. Bye.